Regarding the topography of the neck. At the beginning, we have to explain the borders of the neck region. The neck region is divided by those borders. The superior border, which is, as a matter of fact, it's separating the head region from the neck region, and inferior border, which is separating the neck region from the thoracic region. Regarding the superior border of the neck, we subdivide them to the superficial border and deep border. The superficial border is starting at the chin region and floor of the mouth, and it continues along the lower border of the body of the mandible till the angle of the mandible. It's going upward along the posterior margin of the ramus of the mandible to the external acoustic pore. Then it continues as a mastoid process toward the superior nuchal line, and then it ends up to the external occipital protuberance. This line that you see, it's the superficial border of the neck region that it's separating from the head region. The deep border between the head and neck region, it's not correspond with the superficial border, and the deep border is formed by the external cranial base and a styloid septum. Regarding the inferior border of the neck, which is separating the neck region from the thorax, is starting at the jugular fossa, which is above the manubrium of the sternum. Then it's going along the clavicle till it reaches to the acromion. And then it goes posteriorly to the spinous process of the C7 cervical vertebra, or is called vertebra prominens. The neck region, we subdivide them to the smaller regions. Those subdivision is mainly by the passage of the muscles, and this area, they are usually the shape of the triangular shape. Usually the neck region, it's subdivided to the anterior cervical region, lateral cervical region, and posterior cervical region. Regarding the anterior cervical region, is bordered laterally by anterior border of the sternocleidomastoid muscles in both sides, the right side and left side, in the laterally. Cranially or superiorly is bordered by the lower margin of the mandible, and caudally or inferiorly is bordered by the jugular fossa. So you can see the border of the anterior cervical region. The anterior cervical region, then it's subdivided to the smaller regions that, as we mentioned, that looks like a triangular shape. So the first triangle is submental triangle. Second triangle is submandibular triangle. And very important triangle, which is carotid triangle. And finally, the omotracheal triangle or muscular triangle. Another region of the neck is sternocleidomastoid region. The sternocleidomastoid region, as a matter of fact, it's the region that the muscle is located. The muscle is originated from the manubrium of the sternum and the medial third of the clavicle, and between these two origins there is a fossa which is called lesser supraclavicular fossa or minor supraclavicular fossa, and it's and is inserted to the mastoid process and superior nuchal line. So this region is called sternocleidomastoid region, which is, as a matter of fact, separating the anterior cervical region from the lateral cervical region. The lateral cervical region is bordered by the posterior margin of the sternocleidomastoid muscle anteriorly. Posteriorly is bordered by the anterior border of the trapezius muscle, and inferiorly is bordered by the clavicle. This lateral cervical region in English terminology is called posterior triangle of the neck. The posterior triangle of the neck, furthermore, it's divided by passage of the inferior belly of the omohyoid muscle, which is here. It's subdivided to the omoclavicular trigone or triangle, which has another name which is called major or greater supraclavicular fossa. And the other triangle which is here and is called omotrapezium trigone or triangle, which is in English terminology is called occipital triangle. And finally, this area, it's called the posterior cervical region, or it's called also Nuchal region. The Nucha region is the region which is lying under the trapezius muscle, inferior to the insertion of the trapezius muscle, and at the superior nuchal line, which is the insertion of the trapezius, the superior insertion, and the superior to the vertebra prominence, C7. So the first region that I'm going to talk is the submental triangle, which is the smallest region or triangle at the anterior cervical region. This region is unpaired triangle, which is located between the hyoid bone and the mandible and medial to the anterior bellies of the digastric muscles. So the borders of this submental triangle, they are the medial border of the two bellies of the anterior, the belly of the digastric muscles, then the body of the hyoid bone, and the chin region of the mandible, respectively the mental tubercles of the mandible. The floor of this triangle is formed by the mylohyoid muscle, which is separating the neck region from the sublingual region. And clinically is important that I'm going to discuss. At the preparation that you can see, we can determine those borders. So here you can see the chin or the mental tubercle of the mandible. Then you can see by this yellow line the medial border of the two anterior bellies of the digastric muscles, the anterior belly, the right one, anterior belly, the left one. And finally, this one, it's determining the position of the hyoid bone. So the border or the floor, it's formed by this muscle, which is called mylohyoid muscle. If we want to dissect this submental region and we go from the superficial to the deep region, of course, the first layer that we have to dissect is the skin. Under the skin, then we have the subcutaneous connective tissue, which are usually the loose subcutaneous connective tissue. And between this subcutaneous connective tissue, you see this muscle, which is called platysma. As a matter of fact, the platysma is dividing the subcutaneous connective tissue of the neck region to the superficial layer and deep layer. After this platysma, of course, it's innervated by the cervical or ramus colli of the facial nerve, which is arising from the parotid plexus or intraparotid plexus that in the nervous system we are going to discuss. The platysma, it doesn't reach usually to the midline of the neck region. After the removing of the platysma, then you will, of course, you will reach and you will see this area of the anterior belly and the mylohyoid, that they are covered by the investing layer of the deep cervical fascia. In some literature, it's mentioned as a superficial layer of the deep cervical fascia. So if you remove them,
So then you are reaching to this area and you see the anterior belly and the mylohyoid muscle. It is important that in this area and in the subcutaneous connective tissue, you can see some superficial veins that they are the commencement of the anterior jugular vein that you can see it in this area, and they are draining and forming the anterior jugular veins that they are superficial veins in the anterior cervical region. And also you can see some cutaneous nerves that they are very small, and mainly they are the branches of the mylohyoid nerve that is providing the sensory innervation to the inferior aspect of the chin. Then the blood supply, it's formed by the branch of facial artery that I'm going to discuss. But the very important component of the submental triangle, those are those lymph nodes that they are called submental lymph nodes. The number, they are usually 3 or 4, and they are receiving the lymph from the region of the lower lip, the alveolar process of the oral vestibule at the corresponding area. It means the frontal segment of the mandible, and of course the frontal segment, the teeth that they are located in the frontal segment of the mandible, that they are incisors and sometimes canine. They are draining the lymph, they are draining to the submental lymph nodes, and finally they are receiving the lymph from the tip of the tongue or apex linguae. As I mentioned, the blood supply, it's a branch of the, is supplied by the branch of the facial artery, which is giving submental artery, that it's arising from the facial artery, and it goes through the submandibular triangle, and it reaches to the submental triangle, accompanied with the submental veins that, as I said, then finally they are connecting together, and they are connecting with the anterior jugular vein. The nerve that it's responsible for supplying this area, it's the mylohyoid nerve. As you know, the mylohyoid nerve is branch of the inferior alveolar nerve, which is itself is branch of mandibular nerve, and is arising from the inferior alveolar nerve before it enter to the mandibular foramen, and at the medial aspect of the ramus of the mandible, it goes to the mylohyoid groove, and it's reached to the submandibular triangle, and it goes toward the submental triangle, and it has the motoric fiber that innervating the mylohyoid muscle and anterior bellies of the digastric muscle. And also this mylohyoid nerve, it contains the sensory fiber or cutaneous nerve that is providing the sensory innervation to the inferior aspect of the chin. Finally, the clinical importance of this area, the submental triangle, is that the mylohyoid raphe. The mylohyoid raphe is the area that the two belly or two muscle of the mylohyoid muscle, they are fusing together via this connective tissue that they are forming the mylohyoid raphe. And this is very important for the dentistry and surgery, that it's the place for the surgical intervention and incision. Incision through this mylohyoid raphe, you can reach to the upper structure, which is the sublingual region, and you can drain the abscess at the sublingual region, which is very important clinical aspect of this region. Next triangle that I'm going to discuss at the region of the anterior cervical region, it's submandibular triangle. The submandibular triangle is bordered superficially by the inferior margin of the mandible, the body of the mandible, and the anterior and posterior belly of digastric muscles. Here in this picture, you can see the borders that I mentioned, and here is the inferior margin of the body of the mandible. Here in the preparation, you can see also. Then it's by the anterior belly of the digastric muscle, which is determined here, and the posterior belly of the digastric muscle, which is here. You can see. So this triangle, the outline of this triangle, it's determined by the yellow. It's border of the submandibular triangle. Regarding the anterior belly of the digastric muscle, this muscle is starting or originated from the digastric fossa, which is, as a matter of fact, is at the inner side of the lower border of the mandible, is started, and it going downward and backward, and it's continue as an intermediate tendon. This intermediate tendon, it's the tendon that the two belly of the digastric muscle, they are joining together, and they perforates the stylohyoid muscle. This muscle that it's perforated by this intermediate tendon, and this intermediate tendon it's finally inserted to the greater horn of the hyoid bone by the fibrous loop, which is sometimes lined by the mucosal membrane. The posterior belly of the digastric muscle is originated from the mastoid notch, which is located at the temporal bone, and this is coming downward, and it's continue as this intermediate lobe. The difference between the anterior belly and posterior belly, it's the embryological origin of these two muscles. The anterior belly of the digastric muscle is originates from the first pharyngeal arch, but the posterior belly of the digastric muscle originates from the second pharyngeal arch. That's why we can explain the difference of the innervation of these two muscle from each other. The anterior belly of the digastric muscle is innervated by the mylohyoid nerve that I already mentioned it. It's the branch of the inferior alveolar nerve, which is itself is branch of the mandibular nerve. And posterior belly of the digastric muscle is innervated by the fascial nerve directly, the digastric branch that is coming from the fascial nerve after its exit from the stylomastoid foramen. So this is the border of the submandibular triangle, and if we want to say about the floor of this triangle, the floor is made by the mylohyoid muscle, which is seen here, and partly you can see here. We already discussed about this muscle that is starting and originated as from the mylohyoid line, from the inner aspect of the mandible, and is like a fan-shaped muscle that is going downward and medially, and it's joining together at the mylohyoid ruff. The other muscle that takes part in the floor of the submandibular triangle, and it makes the floor of the submandibular bed, which is the gland, the submandibular gland is located. It's the hyoglossus muscle, and also another muscle that it takes part to this floor of the submandibular triangle is stylogluteus, which is not here, so somehow there is here, and in some literature also you can see the stylohyoid muscle. So those are the muscles that they are making the floor of the submandibular triangle. If I want to dissect this triangle, first from the superficial to the deep region, again, you have the skin that you have to cut the skin of the submandibular triangle. Under the skin is subcutaneous connective tissue that is divided by the passage of the platysma muscle to the superficial layer and the deep layer of the subcutaneous connective tissue. As I mentioned, the platysma is innervated by the cervical branch of the fascial nerve from the parotid plexus or intraparotid plexus. After removing the platysma, in some literature you can see that is written that the platysma is covered by the superficial cervical fascia as well. So after removing of this superficial cervical fascia and platysma, then you will reach to the deeper layer, which is investing layer of the deep cervical fascia or the superficial lamina of the deep cervical fascia. This fascia, it's important at the submandibular triangle at the level of the angle of the mandible, between the angle of the mandible and the sternocleidomastoid muscle, which is flapped here. So in this region, this investing layer, it's becoming very thick, and that's why it's called the angular tract or tractus angularis, and it's separating the submandibular region and the content of the submandibular region. It means the gland and the content of this region from the parotid region. So this is surgically and clinically is very important. For example, it's preventing the spread of infection from one region to the other region and separating the parotid region from the submandibular region, and it's surgically is very important as well as clinically. So this investing fascia or investing layer of the deep cervical fascia is perforated by this vein, which is passing superficially and is a fascial vein. This fascial vein is it has a junction or the connection with the anterior division of the retromandibular vein, which is forming usually the common fascial vein, and finally it's draining to the internal jugular vein. Be careful, the course of the fascial vein is going very superficially to the submandibular gland. So this is very important information during to the operation of the submandibular gland, that this vein is going superficially to this gland, the fascial vein, unlike the fascial artery, as you see, is going deep to the gland, and sometimes it goes inside the material of the glands, but both of them then finally they are going to the face region in front of the anterior margin of the masseter muscle. So this fascial vein, as I said, that is perforating this investing layer, and it goes superficially to the submandibular gland. Then another component of the and the main component of the submandibular region is submandibular gland. As you see, this submandibular gland, it reaches to the both belly of the digastric muscle, and medially it continue through the posterior margin of the mylohyoid muscle, it's turning and it gives a process which is usually is called anterior process, and it's turned at the posterior margin of the mylohyoid muscle, and it entered to the sublingual region, and it's giving from that part the submandibular duct, and in this case, through this posterior margin of the mylohyoid muscle, so there is a communication between the sublingual region and submandibular region, thanks to this pathway of this anterior process of the submandibular gland from the submandibular region to the sublingual region, and this is important for the, for example, a spread of infection from one region to the other region. The submandibular duct, it's arising from this turning anterior process of the gland, and it emerging from the gland in the anterior direction, and runs between the mylohyoid muscle and hyoglossus muscle. So as a matter of fact, between these two muscles, it passed the submandibular duct. So this submandibular gland, as we mentioned it before in GI tract, it's the mixed gland, mainly is producing the serous saliva, and is innervated. Parasympathetic innervation or secretomotor innervation is through the submandibular ganglion, which is receiving the parasympathetic fiber or secretomotor fiber from the chorda tympani, which is a branch of the facial nerve, and it's carrying by the lingual nerve to the submandibular ganglion. So this is then another component of the submandibular region. It's or are the submandibular lymph nodes. They are very important clinically. Usually the number is 3 till 6, and is distributed between the or below the inferior margin of the mandible and around the submandibular gland, and they are collectors of the superficial and deep layers of the most of the facial region. It means that they are receiving the lymph from the cheek region, from the upper lip, from the lateral aspect of the lower lip, from the margin of the tongue, from the most of the facial region. So they are draining to this submandibular lymph node, and also they are receiving the lymph from the submental lymph node and all the groups of the facial lymph node in the face region. So that's why clinical examination of these submandibular lymph nodes, they are very, very important. So if you see in this preparation, again, you can see the border of the submandibular triangle. This is the inferior margin of the body of the mandible. This is the anterior belly, and this is the posterior belly, and this is the intermediate tendon, which is attaching to the hyoid bone. So this is the submandibular region after removing the submandibular gland. So as you see, when we remove the submandibular gland, you can see the course of the facial artery. This facial artery, it's as we mentioned it, it's coming or runs from the carotid triangle as a ventral branch of the external carotid artery. It passes, as you see topographically, is important, is below the posterior belly of the digastric muscle, and also the stylohyoid muscle, and it runs medially deep to the submandibular gland. You see that it's going deep to the submandibular gland toward the superior direction, and when you reach to the inferior margin of the body of the mandible, is joined with the facial vein that is runs superficially, and both of them, they are entering to the facial region in front of the anterior margin of the masseter muscle. And clinically, again, here is important by the compressing of this facial artery against the inferior border of the mandible, you can feel the pulse of the facial artery. And in the case of the bleeding in the facial region, by the pressing of this artery against the inferior margin of the mandible, you can diminish or stop temporarily the bleeding. So this is another component of the submandibular region. The facial artery, as we said, also it gives to the submandibular region the branches, which is called submental artery, that is accompanied with the submental vein. They are a component of the submental triangle as well. And the facial artery also, it gives the glandular branch for the blood supply of the submandibular gland, and also in the neck region, as we mentioned it, it gives the ascending palatine artery that further it gives the tonsillar branch, which is the main source for the blood supply of the palatine tonsil. So this submental artery and submental vein, they are the component of the submandibular triangle as well. If we remove the gland, as you see in this picture, under the gland we have this lingual nerve. The lingual nerve, it's a very important nerve that it runs at the superior part of the submandibular triangle, and it arches toward the anterior direction. And after the crossing of the submandibular duct, we said that the lingual nerve is crossing the submandibular duct 2 times. One is in the sublingual region, and the other one is in the submandibular region. It runs between the mylohyoid muscle and the hyoglossus muscle. So these 3 muscles that you can see it here, they are making the floor of the submandibular bed. So submandibular bed, it's the place that the submandibular gland it's located there. So it means that here you have the mylohyoid muscle, here is you have the hyoglossus muscle, and here you have the styloglossus muscle. And finally, you can see very well after we remove the gland, this intermediate tendon of the anterior belly and the posterior belly of the digastric muscle is piercing the tendon of the stylohyoid muscle. And in this picture you can see. So back to this lingual nerve. Then we said that it's passing between the mylohyoid and hyoglossus toward the sublingual region, and it contained the sensitive innervation for the anterior 2/3 of the tongue and floor of the mouth, and also, as I mentioned, is carrying the parasympathetic or visceromotor fiber to the submandibular ganglion that it's located, and this submandibular ganglion is suspended in the arch of the lingual nerve and located on the hyoglossus muscle. So the position of the submandibular ganglion is on the hyoglossus muscle, as you see, and it's responsible for the secretomotor innervation of the submandibular sublingual glands and the minor salivary glands of the anterior 2/3 of the tongue and floor of the mouth. So this is the submandibular ganglion that we mentioned it. And finally, if you see it again in this picture, the anterior belly and posterior belly and the inferior margin of the mandible. So here you can see the course of the facial artery that after removing of the submandibular gland, it's very well seen. And then we reach to this nerve that it's the hypoglossal nerve. The hypoglossal nerve, it's very important nerve that runs from the carotid triangle to the inferior part, as you see, to the inferior part of the submandibular triangle, deep to the posterior belly of the digastric muscle and the hyoglossus and mylohyoid muscle. So as you see, it passes between the mylohyoid muscle and hyoglossus muscle, is making a arch shape, and it's continuing to the sublingual region together with the vena comitans nervi hypoglossy, or vein accompanied with the hypoglossal nerve. This nerve also is forming the superior border of the very important triangle, which is called Pyrogov triangle. This hypoglossal nerve. This Pyrogov triangle clinically important for the ligature of the lingual artery. You see that the lingual artery is arising from the external carotid artery at the level of the greater horn of the hyoid bone. It goes under the hyoglossus muscle. So we can say that this is the deepest structure in the submandibular region. And here in this triangle, which is bordered superiorly by the hypoglossal nerve, ventrally by the posterior margin of the mylohyoid muscle, caudally is this intermediate tendon, or mainly we can say the posterior belly of the digastric muscle, and sometimes also the stylohyoid muscle, and floor is made by the hyoglossus muscle. So this is the place, the Pyrogov triangle, which is by the opening of this hyoglossus muscle, you can find the lingual. And in the case of the bleeding of the tongue region or lingual region, you can find it and do the ligature of this artery. So again, you can see the pathway of the fascial artery in this preparation. And the next component, it's the mylohyoid nerve that we already mentioned it. It's going under the submandibular gland. So you can see that when we remove the gland, we can find this nerve. It's arising from inferior alveolar nerve, and it's going from the submandibular region toward the submental region for motoric innervation of the mylohyoid muscle and anterior belly of digastric muscle, and sensory innervation of the inferior aspect of the chin. It's a very important structure that we can say here in this area, that according to the topography, so the lingual nerve, the submandibular duct, the hypoglossal nerve, there are the three structures that they are passing between the mylohyoid muscle and hyoglossus muscle, which is important, and also the submandibular ganglion, which is located on the hyoglossus muscle, this muscle, and the deepest structure of the submandibular gland, that it's going deep to the hyoglossus muscle. As you see here is dot line, is the course of the lingual artery, which is important, and it's can be ligated at the submandibular region at the Pyrogov triangle that it's determining here. So here you can find the muscles that they are making the wall of the, or borders of the submandibular triangle here. Here is the anterior belly of the digastric muscle, which is originated from the digastric fossa of the mandible. Then is intermediate tendon, and here is the posterior belly of the digastric muscle, which is
going and attached to the mastoid notch of the temporal bone. And here is the inferior border of the body of the mandible till the angle of the mandible here. At the outer surface of the angle of the mandible is masseter here, which is in the face region. So in the neck region, this triangle that you can see, it's the submandibular triangle, anterior belly, intermediate tendon and posterior belly, and inferior border of the body of the mandible. It's making a border for the submandibular triangle. So the floor of the triangle is made by mainly the mylohyoid muscle, then is followed up with the hyoglossus muscle, and then styloglossus muscle. Sometimes at the intermediate tendon is piercing the passage of the stylohyoid muscle. Here we have at the region of the submandibular triangle, the main component of the submandibular triangle is the submandibular gland, which is the mixed gland, which is mainly production of the serous saliva. It's the function of this gland. What is important topographically is the passage of the fascial vein and fascial artery. So here it's clear that the fascial vein in the face region, the fascial vein is straight and it's located posteriorly to the artery, but the fascial artery, the passage is zigzag or wavy shape, and it goes upward till the end branch, which is the angular artery. So of course here it gives the inferior labial, superior labial, lateral nasal, and the end branch is angular artery. So here in the face region, so you can see the difference between the artery and vein, which is vein is a straight location and is location more dorsally, artery is the wavy and is located ventrally. But at the submandibular triangle, it has a very important course when we are operating the submandibular gland with any reason. So it can be the reason the stone inside the submandibular gland or the tumor. So the most superficial or superficial to the gland, it passes the fascial vein, as you see. The fascial vein, it passes more superficially to the gland, but fascial artery here, it's coming from the deep part of the submandibular gland, and it's sometimes is inside the gland, it's coming toward the surface, and then both of them, it's arising to the face region, from the neck to the head region or the face region here, in front of the anterior margin of the masseter, and at the mandibular body or the corpus of the mandible, it's coming to the face region. And here is the same, the area that you can feel the pulse of the fascial artery by the pressing of this artery against the body of the mandible. So this is important. So first is superficial to the gland, it's the fascial vein. Deep to the gland, it's the fascial artery, but both of them, then it's coming in front of the anterior margin of the masseter to the face region. And of course the fascial artery, it at the submandibular region, it gives the branch here. It's called the submental artery, which is going over the mylohyoid muscle, and then it's going to the submental triangle. Here is the submental artery, as you see, it's branch of the fascial artery here. And here there are the submental vein, it's draining to the fascial vein. So the other branch of the fascial, the branch of the fascial artery in the neck region, it's the ascending palatine artery, which is giving very important source for the
blood supply of the palatine tonsil as a tonsillar branch, and also it's supplying the submandibular gland, the facial artery, as a glandular branch of the facial artery. So here we are again in the region of the submandibular triangle, which is bordered by the anterior belly of digastric muscle, and here is the posterior belly of the digastric muscle. The intermediate tendon is it's passing through this muscle, which is the tendon of this muscle, which is called the stylohyoid muscle. So anterior belly of posterior belly of digastric, and here is the stylohyoid muscle that is going, and it's pierced by the intermediate tendon of the digastric muscle. And in this case, the inferior border of the body of the mandible, they make this triangle, which is called the submandibular triangle. Here, as you see, the submandibular gland, which is the largest component of this area, is removed to see better the structure that we can find it in the this area. As we mentioned it, that superficial to the gland, the facial vein it pass, and the deep to the gland, the submandibular gland, it pass the facial artery. That both of them in front of the masseter muscle, they are going to the face region. This is one. Then, of course, you can see very nice preparation here. The passage of the hypoglossal nerve. The hypoglossal nerve, it's coming from the carotid triangle, and from the carotid triangle is making an arch shape. It's going forward, and it enter to the submandibular triangle, and it goes between the mylohyoid and hyoglossus muscle. It goes continue, and it goes to the sublingual region together with the vena comitans nervi hypoglossi, or the vein accompanied by the hypoglossal nerve. So here in this region, then we have the pyrogoph triangle of the submandibular triangle, which is superiorly is bordered by the hypoglossal nerve, the cranial nerve number 12. Then inferiorly it's bordered by the anterior and posteriorly is bordered by the posterior belly of digastric muscle, our intermediate tendon, which is between the anterior and posterior belly here of the digastric muscle, and here you have the posterior margin of the mylohyoid muscle. So in this area under the hyoglossus muscle, you can do the ligature of the lingual artery, and this area is called the pyrogoph triangle. And it's very important for the ligature of the lingual artery at the submandibular triangle. We have another place for the ligature of the lingual artery, which is the Becklard's angle, and it's in the carotid triangle. It's between the greater horn of the hyoid bone and the digastric muscle, the posterior belly of digastric muscle, or stylohyoid muscle. There is an angle which is called Becklard's angle, but it's located at the carotid triangle. So here, if I a little bit elevate the digastric muscle and stylohyoid muscle, you can see here is the external carotid artery, and here it's the lingual artery. So lingual artery in this area, it's going under the hyoglossus muscle. So as a matter of fact, is the deepest structure at the submandibular triangle under the hyoglossus muscle, and again this area, it's the Becklard's angle, and here it's the lingual artery that you can do the ligature. So here you have in this preparation, you can see the two very important nerve
that is the component of the submandibular triangle as well as sublingual region. First one that we already discussed, this nerve is the hypoglossal nerve, which is passing through the hypoglossal canal, and then it's continue to the retrostyloid part of the parapharyngeal space. It's going toward the superior part of the carotid triangle, and is making an arch shape. It goes to the submandibular triangle between the hyoglossus and mylohyoid muscle, is entering to the sublingual region, and in sublingual region it continue with the vena comitans nervi hypoglossi, or the vein accompanied by hypoglossal nerve. The second nerve that is here and is very important nerve, it's a branch of the mandibular nerve, is lingual nerve. Here, as you see, the ramus of the mandible, it's cutted. Here is the condylar process of the mandible, is the muscular or the coronoid process of the mandible, and here is the ramus of the mandible cutted here till the body of the mandible. So this lingual nerve is arising from the infratemporal fossa from the mandibular nerve. It's going downward toward the sublingual region and toward the sublingual and submandibular region, and also it's passing between the mylohyoid and the hyoglossus muscle, and it's continuing to the sublingual space, sublingual space, and is carrying the sensory or sensitive fiber for the anterior two-thirds of the tongue, and also the taste fiber from the chorda tympani for the anterior two-thirds of the tongue as well, and it's giving the branches for the submandibular ganglion, the parasympathetic ganglion, submandibular ganglion, which is for the secretion of the sublingual gland and submandibular gland, and also the small salivary gland of the floor of the mouth and anterior two-thirds of the tongue. So once more, the lingual nerve, it's coming from the mandibular nerve, and it's going from the infratemporal fossa, passing through the pterygomandibular space between the ramus of the mandible and medial pterygoid muscle. Then it enter to the submandibular and sublingual region that it's located between the mylohyoid and hyoglossus muscle. So this is the important nerve. Next triangle of the anterior cervical region is carotid triangle, which is extremely important clinically, because there it's a place of the bifurcation of the common carotid artery and the place that the internal jugular vein is passing. So this carotid triangle is bordered by the following structure. The laterally, it's bordered by the anterior margin of the sternocleidomastoid muscle, which is here. Then the ventrocranially, it's bordered by the venter posterior of the digastric muscle, or posterior belly of the digastric muscle. And finally, the ventrocaudally is bordered by the venter superior musculi omohyoidei, or superior belly of the omohyoid muscle. So this is the border of the carotid triangle, which is clinically, as we said, is important. And in the deep region, cranially is communicating with the parapharyngeal space with the retrostyloid and the peristyloid part of the parapharyngeal space, and caudally it's continues into the scaleno-vertebral triangle. So regarding the borders, as we mentioned it again in the preparation, we can determine the border. Here is the posterior belly of the digastric muscle. Here is the anterior margin of the sternocleidomastoid muscle, which is the dorsolateral border. Here is the superior or the ventrocranial border, and finally the ventrocaudal border is the superior belly of the omohyoid muscle. Regarding the dissection of this region, so in dissection of this region, so the first layer that we have as usual is the skin. The skin is usually is thin. Under the skin, there are subcutaneous connective tissue, which is again divided to the superficial and deep subcutaneous tissue by the passage of the muscle, which is the platysma. As I mentioned, the platysma is innervated by the cervical branch of the fascial nerve from intraparotid or parotid plexus. And also, it's in some literature you can find that the platysma is covered by the superficial cervical fascia. On the subcutaneous connective tissue, you can find some cutaneous nerves that they are perforating the platysma, and from the deep part they are going to the superficial part, and there are the transverse cervical nerves that they are arising from the cervical plexus. And they are communicating with the cervical branch of the fascial nerve that is supplying the platysma, and they are forming the superficial ansa cervicalis. In this subcutaneous part also you can find variable superficial veins that they are anastomosing with the retromandibular vein, fascial vein, and external jugular vein. So when we remove the platysma, of course, here you can see the border of the platysma in the carotid triangle. This is the transverse cervical nerves that I mentioned that they are arising from the cervical plexus. Here is the communication with the ramus colli of the fascial nerve that in the preparation I'm going to show it to you, and they form the superficial ansa cervicalis, which is containing the sensory fiber from the transverse cervical nerves and motoric fiber from the cervical branch of the fascial nerve. So here in this preparation you can see the platysma, the course of the platysma, how it passes subcutaneously. Then you can see here from the posterior margin of the sternocleidomastoid in midpoint in superior part, there is a Erb's point or punctum nervosum or nerve points that they are the sensitive branch of the cervical plexus they are arising. And here you can see the transversally, it's passing the transverse colli, nervus transverse colli, or the transverse cervical nerve that is subdivided to the superior and inferior, and they are innervating the suprahyoid and infrahyoid regions. Then here you can continue and you can see this superficial ansa cervicalis, which is the anastomosing and communication with this branch of the fascial nerve that I said. It's the ramus colli nervi facialis, or the cervical branch of the fascial nerve, which is coming from the intraparotid plexus. This is the parotid gland, and from the parotid plexus downward, it's coming down and is supplying the platysma. So this is the motoric, and here is the sensitive. So this superficial ansa cervicalis is the mixture of the sensitive and motoric of those branches that I mentioned. Then if we remove the platysma, then you can immediately below the platysma and the skin, you can see the course of the external jugular vein, which is passing superficially and is formed by the junction of the posterior division of the retromandibular vein and also it's receiving the posterior auricular vein, and sometimes also is receiving the occipital vein. This external jugular vein, it's going on the surface of the sternocleidomastoid muscle downward, and it's entering to the region of the sternocleidomastoid, as you see here, and it's draining to the variable, to the subclavian vein usually, or internal jugular vein, or the junction of both these veins. It means that the venous angle, which is the junction of subclavian and internal jugular vein. So the drainage of the external jugular vein is variable. Here in this preparation, you can see the course of the external jugular vein, which is passing superficially. As we said, it's receiving, or is the trunk is formed by the junction, mainly the posterior auricular vein, and also the posterior division of the retromandibular vein. Also, it can receive from the occipital region the occipital vein, and it's going superficially to over the surface of the sternocleidomastoid muscle. If we continue and we remove this vein, the superficial vein, under the vein or deep to this vein, it's the superficial, the sternocleidomastoid muscle, which is covered by the superficial lamina of the deep cervical fascia. In English terminology, it's called the investing layer of the deep cervical fascia. And as you see, this superficial lamina of the deep cervical fascia is enclosing the sternocleidomastoid muscle, and also it continue and enclosing the trapezius muscle. So this is the first superficial lamina of the deep cervical fascia, which is enclosing these two structures. It means sternocleidomastoid and the trapezius muscle. And on the surface of this fascia, or superficial lamina or investing layer, is passing the external jugular vein on the surface of the sternocleidomastoid muscle. Then you can see on the paravisceral space, you can see the structure of the carotid sheath, or vagina carotica. This carotid sheath is very important, and they are enclosing the important structure. Before I continue about the superficial lamina of the cervical, deep cervical fascia or investing layer, as you see this, it's surrounding and covering these two muscles that I said, and posteriorly it's going backward, and it's attaching to the ligamentum nuchae, or nuchal ligament. And anteriorly, it's attaching to the hyoid bone, and superiorly, it's continue and is attaching to the lower border of the mandible. And we said that at the level of the angle of the mandible, between the angle of the mandible and the sternocleidomastoid muscle, is make the angular tract that's separating the submandibular and parotid region. Then it continue posteriorly to the mastoid process and superior nuchal line until it ends to the external occipital protuberance. Inferiorly, it's going downward to the acromion of the scapula and the spine of the scapula. It's continue to the clavicle, and as we said, the trapezius muscle and manubrium of the sternum, which is the place of the attachment of this lamina superficialis of the deep cervical fascia. Then we said that the carotid sheath, but the main component of the carotid sheath is this red line, which is called the preterachal lamina of the deep cervical fascia, which is the middle layer of the deep cervical fascia, is as a matter of fact. This is going medially in front of the carotid vessels and the content of the carotid sheath, and is making and forming the carotid sheath. So the main component of this carotid sheet is the pretrachal lamina of the deep cervical fascia. It's continue behind the infrahyoid muscle. As you see here, there are the infrahyoid muscle. So the pretrachal lamina of the deep cervical fascia, they are covering the infrahyoid muscles and enveloping also the thyroid gland. So they are covering the thyroid gland as a false capsule, because the thyroid gland itself, it has its own true capsule, fibrous capsule. So then this layer, this pretrachal, as you see, is connecting to the opposite side, the layer of the opposite side, and its superior part, this pretrachal lamina, it's fixing with the hyoid bone, and downward it's going in front of the trachea. This is the trachea, which is also it's going to the root of the neck, and also it's entering to the thorax finally, this lamina, and it's continue as a fibrous pericardium. This layer in the deep region, it's fusing with the perivertebral fascia, which is the deepest fascia of the deep cervical fascia, or it's the perivertebral lamina of the deep cervical fascia that I'm going to discuss. And this layer, it's covering it's medially, is behind, as you see, is behind the carotid sheath, and it's extending and is passing in front of the perivertebral muscle. For example, the scaleni muscle is enclosing the scaleni muscle, and longus colli inferiorly, and perivertebral muscles that they are called generally. Then it continue as an endothoracic fascia, and peripherally fused with the at the peripheral part, and centrally it's fusing with the anterior longitudinal ligament, and at approximately it's extended to till the level of the T3 vertebra. This perivertebral lamina, the lamina is extended as an axillary sheath as well, and also not only it's enclosing the perivertebral muscles that I mentioned, also is enclosing the sympathetic trunk and the ganglion, the sympathetic ganglion. So regarding the carotid sheath, that it's in front, it's formed by the pretrachal lamina of the deep cervical fascia, and behind and medially is enclosed by the prevertebral fascia of the deep cervical fascia, or prevertebral lamina of the deep cervical fascia. So the content is very important, and it's extremely important. So if here is the dorsal, and here is anterior, here is medial and lateral, so the lateral component of the carotid sheath is the internal jugular vein. The medial structure inside the carotid sheath is the common carotid artery, which is at the level of C3, C4 approximately, or the superior border of the thyroid cartilage. It's dividing as a bifurcation of the common carotid artery to the external and internal. External is coming out of the carotid sheath, but internal is remain inside the carotid sheath. So the component depend on the which level. So either is the common carotid artery or internal carotid artery. Then dorsally, between the two vessels, they are passing the vagus nerve, which is important. And finally, the anterior aspect of the content of the carotid sheath between the two vessels, it's the deep ansa cervicalis or ansa cervicalis profunda, that it's formed by the superior root and inferior root. So as we mentioned it, the lateral structure, if we open the carotid sheath at the carotid triangle, the lateral structure of the carotid sheath is the internal jugular vein. As you see, parallel with the internal jugular vein, you can see the lymph node, the lateral deep cervical lymph nodes, that they are very important for the lymphatic drainage of the orofacial region. There you can find the jugulodigastric and jugulo-omohyoid lymph nodes, that they are very important. The lymph for the lymphatic drainage of the tongue. Then, of course, if we continue, you can see the veins that they are draining to the internal jugular vein, the facial vein and the lingual vein, also the superior thyroid vein. They are variable. They can join together and they make the linguofacial trunk that they are draining. So the invariable shape, they are draining inside the internal jugular vein, as well as we have the middle thyroid vein that is directly open and drained to the internal jugular vein, and it doesn't have the correspond artery, so we don't have the middle thyroid artery here. So we have middle thyroid vein, which is draining to the internal jugular vein. Then, of course, the upper component of the here you can see the carotid triangle is the hypoglossal nerve. The hypoglossal nerve is the nerve that it's passing through the upper part of the carotid triangle, and it's going between as you see, between the internal jugular vein. It means behind the internal jugular vein and in front of the internal carotid artery, superficial to it. So deep to the internal jugular vein and superficial to the internal carotid artery. Then it continued deep to the posterior belly of the digastric muscle and stylohyoid, and it's going toward the submandibular triangle. That this nerve is carrying the fiber directly from C1 segment, and it's responsible for innervation of the thyrohyoid muscle and the geniohyoid muscle, which is attaching to the mental spine, the superior and the inferior mental spine, the geniohyoid muscle. So this is regarding the hypoglossal nerve. And as we said, the hypoglossal nerve here, it gives the descending branch of the hypoglossal nerve, or the superior root of the deep ansa cervicalis, which is going downward and carrying the fiber from the segment C1, C2, and it's joining from the, here you can see it's the hypoglossal nerve that it's carrying the fiber from the C1 that is innervating the thyrohyoid and geniohyoid muscle. Here is the superior root of the deep ansa cervicalis, which is carrying the fiber from C1, C2, as you see here. Then the in front of the internal jugular vein, here it's the internal jugular vein, and in front of the internal jugular vein, it's joining with the inferior root of the deep ansa cervicalis, which is carrying the fiber from the segment C2, C3 here. And in this case, they make it this loop that you can find it in front of the internal jugular vein, which is the deep ansa cervicalis. It is, and this deep ansa cervicalis is responsible for the innervation of the infrahyoid muscle, except the thyrohyoid muscle, which is directly, it's innervated by the fiber that is carried parallel with the hypoglossal nerve and is taking the segment, the fiber from the segment C1. But it's innervating the superior and inferior belly of the omohyoid muscle. This muscle is the sternohyoid muscle, which is the another infrahyoid muscle, and this muscle is the sternothyroid muscle. As I mentioned, the thyrohyoid muscle is directly innervated by the C1 branch that is carried by the hypoglossal nerve. So in this picture, then you can see that if we remove the internal jugular vein, that in the medial side, you can see the common carotid artery that approximately at the level of the superior border of the thyroid cartilage, which is C3 approximately, it's divided to the external carotid artery and internal carotid artery. Internal carotid artery is located dorsolaterally. External carotid artery is located ventromedially, which is important. And you can see here the bifurcation of the common carotid artery, which is giving the internal carotid artery the dorsolaterally and external carotid artery, which is ventromedially. But for us, it's very important and clinically is important, and we recognize it in the body if the artery doesn't give any branches. So it's the internal carotid artery, and if it gives the branches, so definitely is external carotid artery, because in some case it can exist that the dorsolaterally and ventromedially is not exactly in its place. So, but for the surgeon, it's very important if we see that the artery that it gives the branches in the neck region. So this is definitely the external carotid artery. Regarding the branches of the external carotid artery inside the carotid triangle, it's the superior thyroid artery that it goes downward, and it's supplying the superior and anterior surface of the thyroid gland. That in the artery segment we discussed. Then at the level of the greater horn of the hyoid bone, so it gives the lingual artery, and then which is approximately is here. And then it's the fascial artery that we discussed it, that it's going under the posterior belly of digastric muscle here and stylohyoid muscle, and it's going to the submandibular triangle. It goes deep to the submandibular gland or inside the material of the gland, and then it's going in front of the anterior margin of the masseter muscle at the body of the mandible. Here you can feel the pulse of the fascial artery, or in the case of the bleeding, you can compress this artery and stop and or diminish the amount of the bleeding. So this is important regarding the common carotid artery, that it's going to the carotid triangle. You remember that there is a place that you can against the anterior, the big anterior tubercle, which is called carotid tubercle of the 6 cervical vertebra. You can press the common carotid artery in the case of the bleeding, and it can be compressed against the carotid tubercle of the C6. Then it's important the level of the lingual artery, that the lingual artery it's going deep to the hyoglossus muscle, and in the carotid triangle there is an angle which is called Becklard's angle. If here it's the region of the greater horn of the hyoid bone, and here is the posterior belly of the digastric muscle together with the stylohyoid muscle, which is pierced by this intermediate tendon. This is anterior belly and this is posterior belly. And here is the stylohyoid. So this angle that you can see is the Becklard's angle, that you can find it in the carotid triangle. And it's clinically important because in this angle under the hyoglossus muscle you can find the lingual artery, and in the case of the bleeding at the tongue region or lingual region, you can do the ligature of this artery. Another artery, another place, it was the pyrogoff triangle that already we mentioned it at the submandibular triangle. So pyrogoff triangle, it's located in the submandibular region, and Becklard's angle it's located at the carotid triangle, and both of them it's for the ligature of the lingual artery. So of course, the external carotid artery, in addition of these three ventral branch, it gives the dorsal branch, which are the occipital artery and the posterior auricular artery. They are the dorsal branch, and finally the only one medial branch, which is not here shown. It's the ascending pharyngeal artery that it goes toward the base of the skull, and it's the medial branch of the external carotid artery, which is located medially, and it goes upward toward the jugular foramen and base of the skull. So all above this one, and again I mentioned that the internal carotid artery in the region of the neck region, before that it enter to the skull, it means that the cervical part, it doesn't give any branches. Then it enter to the petrosal part, which is to the carotid canal, and it gives the caroticotympanic artery, which is inside the skull. It is. Then, of course, at the level of the bifurcation, here you can find the widening part at the level of the bifurcation, which is called glumus caroticum, or carotid body. This is the chemoreceptor, which is sensitive to the changing the concentration of the carbon dioxide and oxygen, and is innervated by the vagus nerve and glossopharyngeal nerve that they are calling the herring nerve. Then at the beginning of the internal carotid artery, also you have the dilatation, which is called the carotid sinus, and the carotid sinus is the baroreceptor or pressoreceptor, and it's sensitive to the changing of the blood pressure, and again is innervated by the vagus and glossopharyngeal cranial nerve number 10 and 9, which are called herring nerves. So those are the structure that you can find it in the carotid triangle. And finally, of course, you have between the vessels the internal jugular vein and common carotid or internal carotid artery. You can find the vagus nerve, that it's going downward, and it's between these two major vessels posterior to them, and at this region it gives off the superior laryngeal nerve, which is going medially and caudally to the larynx, that in the preparation that I can say. So after of the dissection of all this structure that we mentioned it, then we will reach to the deeper area, which is covered by the perivertebral lamina of the deep cervical fascia. As I mentioned, this perivertebral lamina, it's extending behind and extended medially behind the carotid vessels, and in front of it's going in front of the deep muscles of the perivertebral muscle. It means longus colli scaleni muscle, for example. Then of course we go, and it's going and continue laterally, and like an axillary sheet, and it's connecting to the anterior longitudinal ligament, and centrally, and it going downward till the level of the T3 vertebra. And between this prevertebral lamina of the cervical fascia, you can find the sympathetic trunk that you can find, and is the deepest structure that it's located inside the carotid triangle, is covered by the perivertebral lamina of the deep cervical fascia. And also you can find the superior sympathetic cervical ganglion, which is also enclosed by this perivertebral lamina of the deep cervical fascia. So in this case, we are dissecting the whole carotid triangle, and from the superficial to the deep layer. So we explain all the branches at the carotid triangle. So here we have the border of the carotid triangle. Posteriorly or dorsally, we have the anterior margin of the sternocleidomastoid muscle. Cranioventrally or ventrocranially, it's the posterior belly of the digastric muscle, and the ventrocaudal border, it's the superior belly of the omohyoid muscle. So this triangle that you can see, it's the carotid triangle that is bordered by those structures that I mentioned. So the superficial structure is already dissected and removed, and we are reaching to the deepest structure, deeper structure in the carotid sheath. So here you can see the internal jugular vein, and parallel with the internal jugular vein, we said that it's the location of the deep cervical lymph node, the lateral deep cervical lymph node. And this structure that you can see, it's the pathology, it's the one of the enlargement of the lymph node. Usually the lymph node is not that much enlarged, so but this is definitely the pathology, and it's either because of the inflammation or it's because of the tumor. So the size of this lymph node, it's enlarged, and it's because it's near to the crossing of the posterior belly of the gastric muscle with the internal jugular vein. This is called the jugulo-digastric lymph node, or Kittner lymph node, which is the important lymph node from the lymphatic drainage of the root of the tongue. And here is the accessory nerve that is supplying the sternocleidomastoid muscle. Then the medial side here, it's the carotid artery, respectively. What I have it here is the external carotid artery, which is I recognized it because it gives the branch, and this is the first branch, which is the superior thyroid artery. And then in front of the continuation of the carotid triangle, it's the submandibular triangle, which is here, it's the submandibular gland, and on the superficial, as we mentioned, it's passing the vein, and deep to that, it's passing the artery. So if I turn the structure, this preparation, you can see the structure of the carotid sheath better. Here, the laterally, it's the internal jugular vein. The medially, it's the common carotid artery, and here is the bifurcation. You can see dilatation, the glomus caroticus, and here it's the dilatation of the beginning of the internal carotid artery, which is the carotid sinus. Between these two and posteriorly, so this is view from posterior side, so that's why this is posteriorly, is the vagus nerve, that you can see very nice the superior ganglion of the vagus nerve below the jugular, inferior ganglion of the vagus nerve below the jugular foramen. And here in this area, it's giving the superior laryngeal nerve, the vagus, it gives the superior laryngeal nerve, which is going toward the larynx here, and is supplying the external branch, supplying the cricothyroid muscle, and internal branch is supplying the sensitive innervation of the larynx above the vocal cord. And of course, if I pull it again, so you can see the external carotid artery, which is giving the superior thyroid. Then here is the lingual artery, and here it's the facial artery. It's the triventral branch of the external carotid artery, which is
which is located inside the carotid triangle. And the external carotid arteries continue up there toward the parotid gland and in the peristyloid part of the parapharyngeal space. And the internal carotid artery, it goes to the retrostyloid part of the parapharyngeal space. Here we have the carotid triangle in the region of the carotid triangle here. It means that we remove the skin, under the skin subcutaneous connective tissue. Between the subcutaneous connective tissue is the platysma. After the removing of the platysma, then at the surface of this muscle, which is a sternocleidomastoid muscle, it passed the external jugular vein superficially with the superficial cervical lymph node, the lateral cervical lymph node, the superficial one. Then we remove the nodes and the vein, the external jugular vein, then we reach to the surface of the sternocleidomastoid muscle, which is covered by the superficial layer of the deep cervical fascia, or is called the investing fascia or investing layer of the deep cervical fascia, which is covering the sternocleidomastoid and the trapezius muscle. Then we will cut the sternocleidomastoid muscle, which is the one of the border of the carotid triangle. The other border was the posterior belly of digastric muscle, which is cutted here, and the superior belly of the omohyoid muscle, which is cutted as well. So after cutting the sternocleidomastoid, we reach to the next layer, which is covered by mainly the peritracheal layer of the deep cervical fascia, and it contains several structures which is very important in the carotid triangle, which is called carotid sheath. And the structure, they are inside the vagina carotica or carotid sheath, and those structures are after the removing of the carotid sheath. On the dorsolateral structure, you can find the internal jugular vein, and parallel with the internal jugular vein, you can find the deep cervical lymph node, the lateral deep cervical lymph node, very famous one that it's classified in this group is the jugulo-omohyoid and jugulo-digastric muscle lymph nodes, that they are very important for the lymphatic drainage of the tongue. The jugulo-omohyoid, where the omohyoid is crossing the internal jugular vein, and jugulo-digastric, it's where the posterior belly of digastric is crossing the internal jugular vein. So the vein, the internal jugular vein, is located dorsolaterally. Then ventromedially at the carotid triangle, you can see it's arising the common carotid artery, which is on the right side. It's coming or arising from the brachiocephalic trunk, and on the left side is directly from the arch of aorta. This common carotid artery is coming from it's going to the scaleno-vertebral triangle, and then it's continue with the carotid triangle. It means that the scaleno-vertebral triangle and carotid triangle, they are communicating together. At the level of the approximately the superior border of the carotid, the thyroid cartilage, the superior border, the common carotid artery divided to external carotid artery and internal carotid artery. The external carotid artery usually is ventromedially, and the internal carotid artery is dorsolaterally. But for clinical aspect, for us is important that the internal carotid artery in the neck region, it doesn't give any branches, but the external, it gives several branches that we are
dividing them to the ventral branch, dorsal branch, medial branch, and end branch. Here, for example, it's the first branch of the external carotid artery, which is going downward, and it's the superior thyroid artery. Is one of the ventral branch that it's going and supplying the superior and anterior aspect of the thyroid gland, which is located in the visceral space at the omotracheal triangle here. So at the region of the bifurcation of the common carotid artery, we have dilatation place, which is called the glumus caroticus, or carotid body, and it's the chemoreceptor. And this chemoreceptor, they are very sensitive and to the changing of the concentration of the carbon dioxide and oxygen, and is innervated by cranial nerve number 9 and 10, which is the hearing nerve is called, and it's important and it's playing role as a chemoreceptor. Then at the beginning of the internal carotid artery, we have another dilatation place here, which is called carotid sinus, which is the baroreceptor or pressoreceptor, and it's sensitive to the changing of the blood pressure, and also is innervated by the hearing nerve or the cranial nerve number 9 and 10 here, and it's mechano or baroreceptors. Then at this level, which is the level of the superior level of the or superior border of the thyroid cartilage, we said that at the carotid triangle, the common carotid artery gives the external and internal branches, internal carotid artery, and then we said that the external, it gives several branches that we mentioned it. So superior thyroid is the first one, then the lingual artery, which is here, it's here, and then it's the facial artery that it's going to the head region, to the in front of the masseter muscle, at the margin of the anterior margin of the masseter muscle, at the body of the or corpus of the mandible. It's arising here, and here it's the continuation of the facial artery, that it has a course of the zigzag or wavy shape course in the face region. The facial artery, it's coming from the here is the cutting of the facial artery. Yes, so here is the facial artery. And the facial artery from the carotid triangle, it's coming forward and it goes to the submandibular triangle. And in the submandibular triangle, in this area, it gives the branch which is called submental artery, that this submental artery is going from the submandibular triangle to the submental region in this area, which is between the two anterior belly of the digastric muscle. The floor is the mylohyoid, and the chin and hyoid bone, it's the border of this submental triangle, and this is the submental artery that it's going to the submandibular region and submental region. Another structure that it's located posterior to these two vessels. It means that the internal jugular vein on the lateral side and on the medial side, the common, which is farther, is divided to external and internal. The common and internal, they are remaining inside the carotid sheath, but external is coming out of the carotid sheath, that it's not furthermore inside the content of the carotid sheath. External carotid arteries continue upward, it entering to the structure of the parotid gland, and it goes to the peristyloid part of the parapharyngeal space, and the internal carotid artery, it's going continuing cranially to the retrostyloid part of the parapharyngeal space. So in this case, you see that the carotid triangle, its cranial, is communicating with this parapharyngeal space. So between these vessels, then the next structure that it's located posteriorly is this structure, very important, is the vagus nerve, cranial nerve number 10, which is coming from the jugular foramen at the base of the head, or external cranial base is coming out, and then it's continue to this carotid sheath, the content of the carotid sheath posteriorly between these two vessels in the carotid triangle. It continue to the scaleno-vertebral triangle, and then it enter to the thorax between the subclavian artery and the subclavian vein and subclavian artery. It enter to the superior mediastinum, and it goes its course through the thorax. So the right vagus nerve, it goes behind the esophagus, and the left one, it goes in front of the esophagus, and they make the vagal anterior, the vagal plexus and anterior and posterior vagal trunk, which are then continue to the esophageal hiatus, to the abdominal cavity. And of course, both of them, they are giving the recurrent laryngeal nerve, which is very important. In the cranial part of the carotid triangle, you can see this structure, which is very important structure, is the hypoglossal nerve, is the cranial nerve number 12. This hypoglossal nerve, it's passing between the internal jugular vein and the internal carotid artery, and it's making an arch. It's anteriorly or ventrally, it continues to the submandibular triangle, and it's making a superior border of the pyrogoph triangle at the submandibular triangle. And then it continue to the between the mylohyoid muscle and hyoglossus muscle in submandibular triangle. It enter into the sublingual, and in sublingual region it's continue with the vena comitans nervi hypoglossi, or vein accompanied by hypoglossal nerve. This hypoglossal nerve, which is making a cranial part, or it's passing in the cranial part of the carotid triangle, it gives a branch which is caudally, it's going at the anterior surface or anterior part of the carotid sheath between the internal carotid artery and the internal jugular vein, and then it's going toward the anterior surface of the internal jugular vein, is making a loop which is called deep ansa cervicalis. So this branch of the hypoglossal nerve is called, the old name, it's the descending branch of the hypoglossal nerve, and also is called the superior root of the deep ansa cervicalis, which is carrying the segment from C1 till C2. Then this superior root at the anterior surface, more or less, of the internal jugular vein is joining with the, here is cutted, is joining with the inferior root, which is coming from the cervical plexus, and it's carrying from the fiber from the C2, C3, and they make a loop, as I said, and this deep ansa cervicalis, it's supplying or innervating the infrahyoid muscle, the motoric innervation of the infrahyoid muscle, and this is the important nerve, which is the content of the carotid triangle and submandibular triangle, and then continue to the sublingual region. Then after removing the internal jugular vein, vagus nerve, the carotid vessels, then you will reach to the next layer of the carotid triangle, which is the perivertebral. It's covered the perivertebral part of the paravertebral layer of the deep cervical fascia, and is covering the deep muscles of the back, and also it's enclosing the sympathetic trunk and the cervical sympathetic ganglion. And in this case, we are at the deepest part of the carotid triangle. So again, here we are at the region of the carotid triangle. Here is the cut edge of the sternocleidomastoid that if I retract it, you can see the accessory nerve, the cranial nerve number 11, which is innervating this muscle. And then immediately below, you can see the content of the carotid sheath, which is laterally is the internal jugular vein. Medially is the common carotid artery, which is in the left side now. It's, as you see, is arising from the arch of aorta. Then again at the level of the superior border of the thyroid cartilage, it's bifurcation of the carotid artery, which is dividing to the external and internal. We said that the external is ventromedially, internal is dorsolaterally, but important is that the external it gives branch. So here you can see very nice, the other side was cutted, here is not cut. So here is the superior thyroid artery, which is going, as you see, to the thyroid gland, and it's supplying the superior and anterior part. It gives the superior laryngeal artery and the artery for the cricothyroid muscle as well. And also here it's the next branch of the external carotid artery, which is the lingual artery. Is at the level of the greater horn of the hyoid bone, and finally it's the fascial artery, which is here is cutted, and it gives the submental branches that we already mentioned it. And here again at the superior part of the carotid triangle, it's the hypoglossal nerve in the carotid triangle between the internal jugular vein and internal carotid artery. It's making an arch shape. It goes between the mylohyoid and hyoglossus muscle to the submandibular triangle. And then, of course, between these two vessels, here and here, and posteriorly is the vagus nerve. You can see the vagus nerve, that it's a component of the carotid sheath in the posterior side. And finally, after a dissection of this layer, so then you have this pretrachal layer, the paravertebral layer of the deep cervical fascia, which is enclosing the sympathetic trunk together with the cervical sympathetic ganglion. So here it's the sternocleidomastoid muscle. As I mentioned, if I retract this sternocleidomastoid muscle, you can see the nerve that is going to this muscle is the accessory nerve that is innervating this muscle. Then under that it's the content of the carotid sheath. So laterally the internal jugular vein, medially the common carotid, and the internal carotid, which is inside the sheath, and the external, which is giving the branches. And of course, between them and posteriorly is the vagus nerve that you can see it's passing here. And anteriorly and between them, this is the superior part of the carotid triangle. This is the hypoglossal nerve. Again, it's making an arch, and here it gives the descending branch of the hypoglossal nerve, or superior root of the deep ansa cervicalis. Usually is in front of the internal jugular vein that it's is joining with the inferior root of the deep ansa cervicalis, and they make the loop of the ansa cervicalis. So in this case, the anteriorly the deep ansa cervicalis, or descending branch of the hypoglossal nerve, laterally internal jugular vein, medially the carotid vessels, and posteriorly is the vagus nerve. So if I remove those structures, then I reach to the paravertebral layer of the deep cervical fascia, and if I open this perivertebral layer of the deep cervical fascia, I reach to this layer, and this structure, which is very nice. Here it's the sympathetic trunk, and the sympathetic trunk, you can see it here, that is going the deepest structure inside the perivertebral layer of the deep cervical fascia, and here is the superior cervical ganglion of the sympathetic trunk, that it's more or less approximately at the level of C2. You can find it in this preparation. So here is the deepest structure inside the prevertebral list, that of course is removed, sympathetic trunk and the superior cervical ganglion, sympathetic ganglion. So here is the pathway of the hypoglossal nerve. As I mentioned it before, here is very nice. You can see at the carotid triangle, this hypoglossal nerve is going behind the internal jugular vein here, and in front of the internal carotid artery. So between these two vessels, so you can see the arch of the hypoglossal nerve that is going forward, and it's continue to the submandibular triangle. The last triangle of the anterior cervical region is called the omotracheal trigon or muscular trigon. This triangle is bordered by following. The superior border is the hyoid bone, here and here. Inferior border is jugular notch of the sternum, or sometimes above this fossa, which is called jugular fossa. Lateral superior part or border, it's formed by the margin of the superior belly of the omohyoid muscle, the superior belly of the omohyoid muscle, and the lateral inferior border is formed by the anterior margin of the sternocleidomastoid muscle. So in two sides, the sternocleidomastoid and omohyoid muscle, here and here, there are the two muscles that they are making the lateral border of this muscular triangle. This muscular triangle, the lateral border, the inferiorly is by the anterior margin of the sternocleidomastoid, and the superior, lateral superiorly it's by the superior belly of the omohyoid muscle, that you can see it, and the same border you have it in the other side. So in this case, this triangle, the muscular triangle or omotracheal triangle, is the unpaired triangle. The content of this triangle, there are very important organs. It means that the larynx is located there, the trachea is located there, the cervical part of the trachea, of course. Then the thyroid gland is located in this triangle. Behind the thyroid gland, it's the parathyroid glands, the four parathyroid glands that are located there. Also the inferior part of the pharynx and the cervical part of the esophagus, which is behind the trachea, pass in the region of the membranous part at the posterior part of the trachea. So this is the content of the omotracheal triangle or muscular triangle. So if we are going to dissect this triangle, so of course the first layer is the skin, which is very thin. Under the skin is subcutaneous connective tissue, and between the subcutaneous connective tissue is the platysma. Is the same as other region that we mentioned it, that the platysma is covered by the superficial cervical fascia and is dividing the subcutaneous connective tissue to the superficial and deep part. The platysma in the neck region, it doesn't go completely to the midline. So some fiber above the sternum can cross from one side to the other side of the platysma. So after you remove the platysma, So then you will reach to so here you can see the platysma. After you remove the platysma, then you will see the superficial lamina of the deep cervical fascia, or English terminology, investing layer of the deep cervical fascia. We mentioned it, that is attaching to the inferior margin of the mandible, and it's going downward, and it's going to the manubrium of the sternum, the superior margin, and also the clavicle that we already explained it. So after this investing layer, under this investing layer, there is another lamina of the deep cervical fascia, which is the pretrachal lamina of the deep cervical fascia. And this is very important because at the superior part of the neck, the superficial lamina and the pretrachal lamina of the deep cervical fascia, somehow they are attaching together and close to each other. But whenever we are going caudally, between the superficial lamina and the pretrachal lamina of the deep cervical fascia, it will be a space that above the sternum. So the superficial is attaching in the anterior margin of the sternum, and the prevertebral fascia is attaching to the posterior surface of the manubrium of the sternum. So then it's creating a space which is called suprasternal interfascial space. They call it suprasternal because it's above the manubrium of the sternum. It's in this area, and interfascial because it's between the investing layer and the pretrachal layer of the deep cervical fascia is located. So the content of this suprasternal interfascial space is the jugular vein. The anterior jugular vein, the left and right anterior jugular vein, they are joining together and they make an arch, and this arch is located inside this suprasternal interfascial space. And it is very important that here is the jugular venous arch, and it's very important during to the surgical approach in the neck region toward the trachea or toward the deep layer. So this structure must be fined and cutted, and then the ligature do the ligature to not make the bleeding, and it's making a problem for the visual field of the operation, visual aspect of the operation field. So the anterior jugular vein, as you know, that they are draining to the external jugular vein. So they are the tributary of the external jugular vein that you can see it here. In this suprasternal interfacial space, except the jugular venous arch, which is, as a matter of fact, is a connection of the right and left anterior jugular vein. It can find a lot of fatty tissue or loose connective tissue, plus some lymph nodes that they are called the suprasternal lymph nodes. So they are important in the content of this fascia. So if we remove this arch, then you can see that the infrahyoid muscles that you can find it, and the infrahyoid muscles, they are covered by the pretrachal lamina of the deep cervical fascia. In the on omotrachal or muscular triangle, you can see the muscle which is sternohyoid muscle, and also here you can see the sternothyroid muscle, and lateral to that here it's the omohyoid muscle. You can see that is passing. So all these muscles, they are innervated by the deep ansa cervicalis, which we mentioned it, that is made by the formed by the union of the superior root from the hypoglossal nerve carrying fiber C2, C1, and inferior root, which is arising from the cervical plexus and carrying the fiber from the C2, C3. And in front of the jugular vein, anterior jugular vein, they make a loop which is making the deep ansa cervicalis and supplying these muscles, except the thyrohyoid muscle, which is directly is innervated by the fiber arising from C1, and it goes parallel with the hypoglossal nerve. So all this muscle, they are innervated, and they are covered by the pretracheal fascia. So pretracheal fascia or lamina of the pretracheal lamina of the deep cervical fascia, they are covering the infrahyoid muscles. The infrahyoid muscles in the center, they don't reach to each other, so that's why it will be appearing approximately the diamond shape of the fibrous connective tissue, which is called linea alba coli or linea alba cervicis. And this is because of in this line, in the midline, the infrahyoid muscles, they don't reach to the midline, which is approximately in each side 3 millimeter width of this part. So again, the superficial lamina of the deep cervical fascia, it's covering the sternocleidomastoid muscle and the trapezius. The pretracheal lamina of the deep cervical fascia is covering the infrahyoid muscle, and it's covering it completely. Then when we go to the posterior part of the or posterior layer of the pretracheal lamina of the deep cervical fascia, we can see that this posterior part or posterior wall of the pretracheal lamina is covering covering the larynx, covering the thyroid glands as a false capsule, and also it's covering the trachea, and it's going downward to the mediastinum, and continue as a fibrous pericardium on the anterior surface of the heart and the pericardium. So it means that all this visceral layer, they are covered and they are located between the posterior wall of the pretracheal lamina of the deep cervical fascia, and posterior to these organs, they are visceral. They are the prevertebral layer of the deep cervical fascia. So if we want to say, when we reach and when we remove this infrahyoid muscles, and you will see to the space which is called visceral space, is the tubular organs of the digestive and respiratory system, that they are passing through the center of the neck, and it lies in the space between the pretracheal and prevertebral lamina of the deep cervical fascia in this visceral space. Later on in the lateral side, we have the paravisceral space that we said it's in the carotid triangle, for example. You can see and it can be seen at the side of the visceral space in the paravisceral space, and they are the content of the carotid sheet that we already discussed it. And finally, the behind of all these organs, there are the retrovisceral space, which is the cleft space between the or behind the cervical organs, all the cervical organs, and caudally is passes through the into the posterior mediastinum. So those are the content and the visceral space that the organs are located here, and we can find it in the omotracheal triangle. So here, when you see the trachea is located in the visceral space, here is the trachea. You can see then it's the thyroid gland that you can see it here. And be careful, the thyroid gland, the isthmus of the thyroid gland is located approximately between the second till fourth tracheal cartilage, the hyaline tracheal cartilage. And this is important landmark for the maneuver, which is called the surgical intervention, which is called the superior and inferior tracheostomy or tracheotomy that I'm going to discuss. And finally, you can see the component of the larynx, which is located in the visceral space at the muscular or omotracheal triangle. Then, as we said, this isthmus, which is here and here, it's a landmark. It was located between the second and fourth tracheal cartilage. Then another structure, after we remove this pretracheal layer of the deep cervical fascia, then we reach to the surface of the trachea. The trachea in this part is a little bit going more toward the deep region, and that's why on the anterior surface of the trachea, which is called the pretracheal region, you can find the vein that they are called the inferior thyroid veins. They are appearing as a two veins, the right and the left inferior thyroid vein. Sometimes also these two veins, they can join together and anastomosing together, and they make the venous plexus, which is called the vena thyroida impar or impaired thyroid vein plexus. So they are making or forming a plexus which is called impaired thyroid plexus or unpaired thyroid plexus, that it's communicating these veins with the middle and superior thyroid veins. The middle and superior thyroid veins, as we discussed, they are the tributaries of the internal jugular vein, but the inferior thyroid veins, they are usually draining to the brachycephalic veins. It means, as a rule, the right one, it's draining to the right brachycephalic vein. The left one is draining to the left brachycephalic vein. But in the case that they are making impaired thyroid plexus, so it will be only one plexus. So usually it's drained, this impaired thyroid plexus, it drained to the left brachiocephalic vein. The inferior thyroid vein that you can see, they are located in front of the trachea, so it is important during to the surgical procedure of the inferior tracheostomy. So we have to be careful not to cut them, so they can cause the bleeding. This plexus thyroidos impar, or this unpaired thyroid plexus, as we said, that is draining and open to the left brachiocephalic vein. This is the vein that they are receiving the blood from the esophagus, the trachea, and also the inferior laryngeal veins. And usually they contain the valve, and as we said, that they are draining, if it is impaired, to the brachiocephalic vein, the left one. Then, of course, the next structure that you can see it in the muscular triangle or omotracheal triangle, since we have a thyroid gland here. So, of course, we have the blood supply of the thyroid gland, that the superior thyroid artery, which is arising from the external carotid artery. It's going downward, and it's supplying the anterior and superior part of the thyroid gland, that it's giving also the superior laryngeal artery, the cricothyroid artery, for the muscle of the cricothyroid muscle. And also, of course, we have the inferior thyroid artery, which is branch of the thyrocervical trunk, which is arising from the scaleno-vertebral triangle, and it goes upward, and it's supplying the inferior aspect and the posterior aspect of the thyroid gland. So this inferior thyroid artery is, as we said, that is one of the branch of the thyrocervical trunk, which is arising from the subclavian artery, the intrascalenic part, and it's passing upward. It has a very important course because it's going in front of the vertebral artery and longus colli muscle. Then it turning medially behind the content of the carotid sheath, and then it's giving the branch, which is the inferior laryngeal artery. Inferior laryngeal artery and inferior thyroid artery, it has a very important course together with the recurrent laryngeal nerve, which is passing from in this area between the trachea and esophagus, in the lateral surface, the fissure between the trachea and esophagus. Here it's going up there. So that's why we have to be careful during to the ligature of this inferior thyroid artery. Be careful of the passage of the recurrent laryngeal nerve. The superior thyroid artery, it has the very common course with the superior laryngeal nerve. Also we have to be careful of this nerve during to the ligature of the superior thyroid artery. The next artery that also in some literature they are mentioning, and also it's in the pretracheal region, you can find it, is the arteria thyroida imma. Arteria thyroida imma, it's the artery that usually is arising, is variable, is arising either from the arch of aorta or the brachiocephalic trunk, or sometimes vertebral artery is variable. So it's entering to the muscular triangle in front of the trachea, and it's going upward toward the isthmus of the thyroid gland. And of course, those arteries, they are anastomosing together like a vein, that they are anastomosing together. Arteria thyroida imma also, it has a clinical importance because again, during to the tracheostomy, so it can be cutted, unwanted accident, and it can cause the bleeding, and finding this artery and stopping of this bleeding then is very difficult, and because the trachea in this area is going more deep, and then it can make a problem for the visual field of the operation place or operation field. So those are about the blood supply of the thyroid gland. And in this muscular triangle, of course, we can do some surgical procedure. One of the surgical procedure which is here is called coniotomy or cricothyrotomy. It has different name. So this is the very important maneuver or incision which is made through the skin and the membrane or the ligaments of the median cricothyroid ligament, which is here, and by cutting off the median cricothyroid ligament, in this case, you can in the emergency case, you can establish the airway during to the some emergency case that for example, the airway obstruction by the foreign body, angioedema, or the very massive facial trauma. So this is a very important procedure that you can do it as a first aid and save the patient's life in the case of the obstruction of the upper airway. So here it's the coniotomy, either by the cutting of this ligament, the median cricothyroid ligament, or by the puncture of this ligament by several needles, they call coniopuncture. As I said, that there are different names for this procedure, like thyrocricotomy or cricothyrotomy, or emergency airway puncture, or coniotomy. It's the similar name for this this procedure, which is you can do it in first aid as a saving of the life of the patient. Because here in this region, there is no major vessels or nerves, so you just cut the skin. Under the skin is subcutaneous connective tissue, and you go directly reach to the median cricothyroid ligament, and you can open it and reach to the infraglottic cavity of the larynx. Another procedure that it's done in this area, there are the superior tracheotomy or tracheostomy, and also the inferior tracheostomy or tracheotomy. And this superior and inferior is the name is arising and is chosen according to their relation to the isthmus of the thyroid gland. As we said, that isthmus of the thyroid gland is located between the second and fourth tracheal ring, the hyaline tracheal ring cartilage, and above the isthmus at the trachea, you can cut it sagittally, and it's called tracheotomy or tracheostomy, the superior one, or above the manubrium of the sternum, so below the isthmus, you can do the cut which is inferior tracheotomy or inferior tracheostomy. This is the surgical procedure under the general anesthesia. You cannot do this surgical procedure at the in the first aid to help the patient. So this is goes under the general anesthesia to ensure the airway pathway, for example, during before the operation of the larynx or tongue operation, or any case that you need the to ensure the airway pathway. So those are about the muscular or omotracheal triangle, and in this case we are finishing the region of the anterior cervical region or anterior neck region. So here we have at the region of the anterior cervical region, you see here the submental triangle, which is bordered by the two anterior belly of the digastric. This is the floor, which is the omohyoid muscle, separating it from the sublingual region. Then it's the chin area of the mandible and or protuberantia mentalis, and here is the hyoid bone. Then under that it's the omotracheal triangle or muscular triangle, that in the surface, the first layer, it's the skin, and under that the subcutaneous connective tissue, which between the subcutaneous connective tissue, again we can find the platysma, which is usually doesn't reach to the midline of the neck region. Then after removing of the platysma, you will reach to the superficial lamina of the cervical fascia or investing layer of the cervical, deep cervical fascia, which is covering the, as we said, the sternocleidomastoid and trapezius muscle. Then it's going to the pretracheal layer of the deep cervical fascia, which is covering those muscles that they are, these muscles that they are infrahyoid muscle. Just to inform you that in the superior part, the superficial or investing layer and the pretracheal fascia, they are fusing together, but whenever we go to the pretracheal region, this is the trachea, and anterior to that we have pretracheal region. We have these two fascia or two layer. It means investing layer and pretracheal layer. They are separating from each other, and between them, in front of the jugular notch, it's the suprasternal interfacial space that it contains the arch of the jugular arch, which is the connection of the two anterior jugular vein that in front of the trachea they are joining together and they make the jugular venous arch in front of the trachea. And in this space, the interfacial suprasternal space, you can find some fatty tissue and also some lymph node, the suprasternal lymph node. This arch is important because during the tracheostomy, the procedure that you cut the trachea, so you have to ligate this jugular venous arch. Then, so after we said that this pretracheal list or lamina of the deep cervical fascia, it's covering the infrahyoid muscle. Infrahyoid muscles, they are the most lateral muscle is the omohyoid. This is the cutting of the omohyoid muscle, which is the superior belly, and then it continue as inferior belly. Then this muscle, it's the sternohyoid muscle under this, and here also the sternohyoid muscle, here the other side the omohyoid muscle. Under the sternohyoid muscle, here it's the part of this muscle which is the sternothyroid muscle, which is from the sternum to the thyroid gland, and then from the thyroid it continue as this muscle which is the thyrohyoid muscle. Those muscles, they are innervated by the, as we mentioned, innervated by the deep ansa cervicalis, which is arising from the root of the superior root from the hypoglossal nerve and the inferior root from the cervical plexus. And all of them, they are containing the fiber from C1 till C3 together, and is innervated by this deep ansa cervicalis, and also a direct branch of the hypoglossal nerve from the, which is carrying the segment from C1. So after removing of this pretracheal layer of the deep cervical fascia and exposing of the this infrahyoid muscle, then you are reaching to the visceral layer or visceral layer of the this anterior cervical region or the omotracheal region. So as you see here, the pretracheal list also is covering the thyroid gland, and the thyroid gland not only it has this layer, the coverage of this pretracheal layer, which is making a false capsule for that, but also it has its own capsule. And as you see, we have the right lobe and the left lobe of the thyroid gland, and sometimes, and between them it's the isthmus of the thyroid gland, which is located approximately at the level of, here is the trachea, first ring, second ring, is at the level of second ring till fourth ring of the cartilage part of the trachea. So here it's the location of the isthmus, and sometimes from isthmus is variable pyramidal lobe of the thyroid gland also it can exist. So according to the isthmus, this procedure that I said that is tracheostomy is done by under the general anesthesia. So if it is above the isthmus, you cut the trachea, and if it is below the isthmus, you cut the trachea, the sagittal, above the jugular notch of the sternum. So it's called superior tracheostomy and inferior tracheostomy that you can see here. And another procedure that it's in the first aid, you have to know it. It's the coniotomy, which is the cutting of the cricothyroid ligament, the median cricothyroid ligament. This area, it's the coniotomy. So in this area, the omotracheal region or muscular triangle, you do these procedures that they are important, and here it's the cricothyroid muscle, is the muscles of the larynx, which is innervated by the superior laryngeal nerve, the external branches. Then after the trachea, so of course in the pretracheal region, not only we have to pay attention to the venous arch, the jugular venous arch, which is the connection of the two anterior jugular vein in the superficial region, but whenever you reach to the anterior part of the trachea, also you have to pay attention about the vein, which is called the plexus thyroideus impar, or impaired thyroid plexus, which is a connection of either it's the connection of the two left and right inferior thyroid vein, and they make it a plexus, or the inferior thyroid vein separately, they can come to this area and supplying the lower pole of the thyroid gland here. So this is also important, and another important in this pretracheal region is the arteria thyroidea imma, which is mainly is variable, is usually is arising from the arch of aorta, is passing through in front of the trachea in this area. This structure it's important during this procedure, the tracheostomy, because cutting of these vessels, it can make the bleeding, and in this case the view of the operation field, it will be worse, and it can be complication during to this procedure of the inferior tracheostomy. Then of course under the trachea you have the esophagus, that is located in the parius membranosus, or the membranous part of the trachea posteriorly. And be careful always between in the lateral side, the fissure between the trachea and esophagus, you find the nerve which is called the recurrent laryngeal nerve. This recurrent laryngeal nerve, which is here, it's arising from the vagus on the left side, is making a loop around the arch of aorta, and the right side is making a loop around the subclavian artery, but always it's coming back to the neck region, so that's why they call it recurrent laryngeal nerve. And you can find it always in the cross section of the neck also. Pay attention to that it's always between the trachea and esophagus in the lateral side. Through this fissure it's passing, and it's giving the inferior laryngeal nerve, which is supplying the motoric innervation of the muscles of the larynx, except the cricothyroid muscle, and also it's supplying the sensitive innervation of the larynx below the vocal cord. So here you have the pretracheal region. Here is the trachea, here is the thyroid gland, here is the cricoid cartilage at the level of C6, where the larynx finishing and trachea is starting, and pharynx is finishing, and the esophagus is starting or begins. We said that here in the pretracheal region, we have to be careful of the this plexus thyroideus impar or impaired thyroid plexus, which is the joint junction of the left and right inferior thyroid vein, and this vein it draining usually to the left brachiocephalic vein. So this is the left brachiocephalic vein, this is the right brachiocephalic vein, that they are forming the superior vena cava. So the here in this area at the pretracheal region we have either the separate left and right inferior thyroid vein, or they make a plexus which is called plexus thyroideus impar here in front of the trachea, that we have to be careful during the inferior tracheostomy. So next region of the neck is the sternocleidomastoid region. As a matter of fact, the sternocleidomastoid region is the region of the neck which is the muscle, this muscle is located. This is a very important muscle of the neck, which is separating the two regions of the neck, which is the anterior cervical region from the lateral cervical region. The anterior cervical triangle is described as a midline that anteriorly passing through the neck, and the anterior border of the sternocleidomastoid posteriorly, and the lower border of the or lower margin of the body of the mandible superiorly. The posterior triangle, it's describing by posterior border of the sternocleidomastoid, and which is posterior border, which is located in anterior border, and the anterior border of the trapezius muscle, which is in the posterior border, and the inferior border, it's the middle third of the clavicle. So this sternocleidomastoid, it's the rhomboid muscle which is originated from the manubrium of the sterni, or manubrium sterni, or the sternal manubrium, and the medial portion of the clavicle. So those are the border of the anterior border and posterior border of the muscle. Yet you can see it in this area. And then there is insertion of the sternocleidomastoid is the mastoid process of the temporal bone in this region, which is continuing posteriorly toward the superior nuchal line. So the origin of the muscle, it's originated from the, as we said, the sternum, the manubrium of the sternum, and the medial portion of the clavicle. Between the two origin of the sternocleidomastoid muscle, which is here and here, there is a fossa which is called the minor or lesser supraclavicular fossa, which is located between the two origin of the sternocleidomastoid, the sternal and clavicular origin of the sternocleidomastoid muscle. So this muscle, if we want to dissect, the first layer is skin. Skin in the upper portion, whenever we are going toward the head region, is usually thicker, and whenever we go to the lower portion, which is going toward the to the thoracic region, so it's becoming thinner. Then under the skin is subcutaneous connective tissue, which is between the subcutaneous connective tissue, as we said several times, is located platysma, which is covered by the superficial cervical fascia. And whenever we remove this platysma, usually doesn't cover this area, the lesser supraclavicular fossa. And also, as we mentioned, the platysma usually doesn't reach to the midpoint or midline of the neck. Only above the sternum, some fiber of the platysma, they can cross over from one side to the other side. Then when we remove the platysma, below the platysma, then you can find the superficial vein. This superficial vein that you can see here is the external jugular vein that we discussed. This external jugular vein is formed by the union of the mainly the posterior division of the retromandibular vein, which is coming out from the from the parotid gland, and the posterior auricular vein, and also the occipital vein also can drain here. So anyway, under the platysma, it means deep to the platysma and superficial to the superficial layer of the deep cervical fascia, or superficial to investing layer on the surface of the sternocleidomastoid and the superior part of this muscle. You can see vertically it goes the external jugular vein. It's receiving also the anterior jugular vein also, and it's going downward and is usually drained into the subclavian vein usually, or can be also internal jugular vein or the junction between these two. So the passage of the external jugular vein, as you see in the superior part in the region of the sternocleidomastoid, but then when we go to the inferior part of this vein, so it reached to the this area which is called the omoclavicular triangle, and or another name is the greater. Here it was lesser or minor, but here is the greater supraclavicular fossa, or the major supraclavicular fossa. So it's going downward to the medial portion of the greater supraclavicular fossa and drain to those veins that I mentioned. So parallel with the with the external jugular vein, also you can see the lateral superficial cervical lymph node that they are parallel with this vein. They are located near to the wall of this vein. Then when we remove this vein, then here it's the major or the greater supraclavicular fossa. So when we remove this vein, under this vein or deep to this vein, it's the fascia, which is called the here you can see the part of this fascia, the anterior layer of this fascia, which is called the superficial layer of the deep cervical fascia, or investing layer of the deep cervical fascia, which is it's divided to the two anterior and posterior layer, or superficial and deep layer, and it's enclosing the sternocleidomastoid here, and then the trapezius muscle here in this region. So the investing layer, they are enclosing these two muscles, the sternocleidomastoid and the trapezius muscle, by the division to the anterior and posterior layer. Then when we remove this superficial cervical fascia, then you will reach on the surface of the sternocleidomastoid, and approximately the border between the middle third and the superior third of the sternocleidomastoid muscle, posterior margin of it, or sometimes they call it at the midpoint of the length of the sternocleidomastoid, that the superior portion, there is a place which is called Erb's point, or punctum nervosum, or the nerve point, that the sensitive innervation of the cervical plexus that are arising from this area. So the sensitive innervation of the cervical plexus that they are arising from the punctum nervosum or nerve point or Erb's point. They are these nerves that is lesser occipital, which is going cranially. It's going in the related to the upper third of the sternocleidomastoid. In the posterior margin of the sternocleidomastoid, it's going upward and it reaches to the occipital region that is innervating the part of the posterior parietal and occipital region area. The next nerve that it's here, and we discussed all these nerves in the cervical plexus. It's the greater auricular nerve that you can see here. Here is the lesser occipital that we explained it, the pathway. Here is the greater auricular or nervus auricularis magnus, which is going toward the auricle, and then it's divided to the anterior and posterior region, and it's responsible for the sensitive innervation of this area, and also the lower portion of the the parotidomasceteric region as well. So this is another then very important. It's this transverse cervical nerve or nervus transversus colli that is crossing over the sternocleidomastoid from the punctum nervosum, and also piercing the fascia of the superficial fascia or investing layer, and it's continue. And as you see here, it continue, and then it's divided to the superior branch and inferior branch. The superior branch is usually responsible for the innervation of the suprahyoid area or the region of the neck, and the inferior branch is responsible for the sensitive innervation of the infrahyoid region of the neck. This superior branch then it continue, and it's anastomosing with the this branch which is the ramus colli of the fascial nerve, or the cervical branch of the fascial nerve, which is coming out of the parotid gland from the parotid plexus or intraparotid plexus. And this anastomosing between the transverse cervical nerve, which is a sensitive, which is contained the sensitive fiber, and the cervical branch of the parotid plexus of the fascial nerve, which is the motoric. So it's making this anastomosing, which is called the superficial ansa cervicalis. So you can see here the superficial ansa cervicalis, which is the anastomosing between the transverse cervical and the cervical branch of the fascial nerve, the motoric fiber, and this is the ansa cervicalis superficialis or superficial ansa cervicalis. So this ramus colli or cervical branch is innervating is responsible for innervation of the platysma. So there are different variable pathway of this transverse cervical. In mostly they are going under the external jugular vein, but in some case you can see that the passage is going over the external jugular vein as well. So another important thing, as you see those, the transverse cervical, the sensitive branch of the cervical plexus, they are penetrating this superficial layer of the deep cervical fascia or investing fascia. This investing layer of the deep cervical fascia is cranially, it's continue, as we mentioned it, to the parotid gland, and they make the parotidomasceteric fascia like a capsule. Also, they are dividing to the anterior and posterior layer, and it's enclosing the parotid gland, and that's why enlargement of the parotid gland due to the edema can be painful, because this capsule is tough, And also we said that in this region between the angle of the mandible, near to this angle of the mandible between angle and the sternocleidomastoid, so there is an angular tract, or tractus angularis is the strongest part of this investing layer, or the parotidomastheteric fascia, which is separating the parotid gland or parotidomastheteric region from the submandibular gland in the submandibular region, which is clinically important. For example, is preventing the spread of infection from one region to the other region. So this is another important things that I wanted to say. And finally, the last sensitive innervation from the punctum nervosum, they are the supraclavicular nerves that we subdivide them to the medial group, intermediate group, and the lateral group, that they are going inferiorly downward, and they go in front of the clavicle, and they go to is a component of the lateral cervical region that we are going to discuss. Regarding the sternocleidomastoid muscle, the action of this muscle is if it's a unilateral action, it means that if in one side it's contract, it's tilting the head to its own side. It's the side of the contraction, and rotation of the neck and head to the, or face to the opposite side. It means in the contralateral side. If they both sides they are contracting this muscle, they are making the flexion of the neck, and also this muscle, it's considered as a accessory muscle of the inspiration. It means that is playing role by the raising of the sternum upward. So it's assist in force inspiration or inhalation muscle. So it's considered as a accessory muscle of the inspiration. The innervation of this muscle is by the accessory nerve. The spinal root of the accessory nerve is innervating this muscle together with the trapezius muscle. This nerve, it's arising from the spinal root of the cranial nerve number 11, and also they are containing some proprioceptive fiber, the sensitive fiber that they are carrying from the second and third cervical segment of the spinal nerve. Regarding the blood supply of this sternocleidomastoid muscle, this muscle is supplied by the sternocleidomastoid branch of the, usually in upper portion by the branch of the occipital artery, and for the lower portion by the superior thyroid artery. Also, there are some variables or branches that they can come directly from the external carotid artery as well. Another important regarding the action that we said, if there is a disorder or the congenital disease, which is called congenital muscular torticollis, this is very rare musculoskeletal disorder, which is by the the characteristic of this disorder is the unilateral shortening of the sternocleidomastoid. It means that one side of the sternocleidomastoid, it's becoming very short congenitally, and it's then the clinical manifestation is the ipsilateral head tilt and contralateral rotation of the face and chin. It's the consequence of this torticollis. Then another important things about the sternocleidomastoid region, As you know, the omohyoid muscle, which is the infrahyoid muscle, is the muscle that is covered by the pretracheal layer of the deep cervical fascia, and it has the superior belly and inferior belly. So the intermediate tendon that it's connecting the superior belly and inferior belly of the omohyoid muscle. They are enclosed by this pretracheal layer of the deep cervical fascia in its lateral margin. And this fascia, together with the muscle, the omohyoid muscle, they are connected by the to the carotid sheath, and mainly it's very close relation with the wall of the internal jugular vein. So that's why the contraction of the omohyoid muscle, it can cause in the deeper layer the dilatation of the diameter of the internal jugular vein. Sternocleidomastoid muscle, it has topographical relation with the different regions. Generally, we divide them like a superior 1/3. It has relation with the infratemporal fossa, the middle third of the or middle portion of the muscle is related or has a relation with the carotid triangle, and the inferior third of the this muscle, it has a relation with the scaleno-vertebral triangle. Regarding the superficial relation of the sternocleidomastoid, as we said, is the skin, the subcutaneous connective tissue platysma, the external jugular vein, and the lateral superficial cervical lymph node, that they are parallel with this vein. They are located. The greater auricular nerve and the transverse cervical nerve, and also finally the superficial lamina of the deep cervical fascia, or investing layer of the deep cervical fascia, that we said that is splits to the two anterior and posterior layer and enclosing this muscle together with the trapezius muscle. Also, it has a relation with the tail of the parotid gland, also, that we said that it's covered by the capsule, which is continuation of this investing layer to the head region. The deeper relationship of this muscle, as we said, to this infratemporal fossa, carotid triangle, scaleno vertebral triangle in the upper portion. So it means that it has relation with the posterior belly of the digastric and deep muscle of the neck region, like longissimus capitis or splenius capitis. Then the middle part of this gland, it has in deep portion related with the levator scapulae, scalenus anterior, and middle scalenus and posterior scalenus. So generally all the scaleni muscle, then the inferior belly of the digastric muscle, inferior belly of the omohyoid muscle, then the inferior relation, it's related with the internal jugular vein, for example, in the middle portion as well, with the vagus nerve, with the content of the carotid sheath, and the lower portion, it has a relation with the brachial plexus, and also the subclavian artery, inferior thyroid artery, and those branches of the thyrocervical trunk that we are going to discuss it in the lateral cervical cervical region. So this nerve point and Erb's point also is the place for the applying of the anesthesia, which is called nerve point block. Or the cervical plexus nerve block. Anesthetic agent is applied and injected to this site as well. So that's all about the sternocleidomastoid region. Here you have the sternocleidomastoid region. This region it's the same region that this muscle is past, and it's coming from the sternum and clavicle. It goes to the mastoid process and the superior nuchal line. In this region, first is a skin that we said, then is subcutaneous connective tissue with some part of the platysma, and then under the platysma, then we have this vein, which is the external jugular vein. External jugular vein, it's passing and it's running superficially to the superficial layer of the deep cervical fascia, or English terminology is the investing layer of the cervical fascia, which is covering the sternocleidomastoid. So before this investing layer, you have superficially it's the external jugular vein, which is formed by the union of the posterior auricular and occipital, and also the posterior division of the retromandibular vein, forming goes caudally, is under the skin. Sometimes in people you can see this vein that is go caudally and it's draining to the subclavian vein or internal jugular vein, or the junction of both of them. It's variable, but mainly it's draining to the subclavian vein. So this is the superficial pathway of the external jugular vein. Then, of course, when you remove it, and parallel with this vein, you can find the superficial lateral cervical lymph node. And then when you remove it, then you have the investing layer, which is covering the sternocleidomastoid. The posterior aspect, it was the sensitive branch of from the cervical plexus, from the Erb's point or punctum nervosum. And after removing, then you reach to the, here you can see the accessory nerve that is supplying the sternocleidomastoid and trapezius muscle. And of course, when you retract the sternocleidomastoid, then you will reach to the carotid triangle that already is explained. And here is the internal jugular vein, the common carotid, which is divided to the external internal, and posteriorly it's the vagus nerve. And here in this area, it's passing anterior to the scalenic, anterior scalenic muscle, the phrenic nerve, that is accompanied with the ascending cervical arteries passing. So here you have the sternocleidomastoid region that we said that it's according to the length and the position of this muscle. As we mentioned, the muscle is originated from the sternal manubrium of the sternum, the superior border from the sternal notch, and the medial third of the clavicle. So here is the clavicle, it's cutted here, you can see, and here is the manubrium of the sternum. So we have two origin. One origin here is the sternal head, and the other is the clavicular head. And under that, these two origin, there is the fossa, which is called the lesser supraclavicular fossa. So this is topographically, is located between the two origin of the sternocleidomastoid. So lesser fossa, supraclavicular fossa. Then the muscle is running and it's inserted to the mastoid process and superior nuchal line. We said that in a midpoint of the way of the length of the sternocleidomastoid muscle, here in the superior portion of this midpoint, you can see the Erb's point or punctum nervosum, that the sensitive
branch of the cervical plexus is arising from this area that we already discussed.
After the anterior cervical region and the sternocleidomastoid region, toward the posterior and lateral part, so you have the lateral cervical region, or in English terminology, you can find it as a posterior cervical triangle. This posterior cervical triangle, which is bordered by the posterior margin of the sternocleidomastoid muscle and anterior margin of the trapezius muscle, and superiorly, the apex of this triangle is toward the mastoid process. And in this area near to the mastoid process, if you remember, we have a groove for occipital artery. The occipital artery is passing through the groove of the occipital artery at the temporal bone. And finally, the inferior border is by the middle third of the clavicle. This lateral cervical region, or the posterior cervical triangle, by the passage of this dot line that you can see, it's the course of the inferior belly of the omohyoid muscle. This inferior belly of the omohyoid muscle, it's subdividing this posterior cervical triangle to the bigger triangle above the inferior belly of the omohyoid, which is here, which is called the omotrapezium triangle, or in English terminology is occipital triangle. And lower to the inferior belly of the omohyoid, it's the omoclavicular triangle, which is also in the deep portion is called the greater supraclavicular fossa, or the major supraclavicular fossa. Regarding the borders of the lateral cervical region, or the posterior cervical triangle, which is here. So once more, the apex, it's the mastoid process, and near to this area of the apex is past occipital artery. The inferior border is middle third of the clavicle, which is important. And as we said, the above the clavicle, this triangle, it's becoming in deep region. It's called the region which is called greater supra clavicular fossa, or the major supraclavicular fossa that you can see in this picture. So the anterior border is the posterior border of the sternocleidomastoid, and the posterior border is anterior border of the trapezius muscle. So this is the occipital, this is the posterior cervical triangle, or the lateral cervical region. So this region. So this is the border, and after that we have to dissect. So again, the dissection of the neck region in the lateral cervical region, we started as a skin, the first layer. The skin is like a sternocleidomastoid region. Whenever we go toward the head region is becoming more thick, but whenever we close to the thoracic region, it's becoming thin. Under the skin is subcutaneous connective tissue, which is, then you can find the platysma, which is covered by the superficial cervical fascia. And as you see, the platysma also, it's perforated by the sensitive branches that they are arising from the punctum nervosum that already we discussed, like transverse cervical and supraclavicular nerves. Then, of course, the next layer. So if you here you can see the occipital, the posterior cervical triangle. Then the next layer is the after removing the platysma. So it's the superficial lamina of the deep cervical fascia. This is the investing layer or the superficial lamina of the deep cervical fascia that, as we mentioned it, so it's divided to the anterior and posterior layer, and it's enclosing the sternocleidomastoid and also enclosing the trapezius muscle. Then superficial to this investing layer or the superficial lamina of the deep cervical fascia, you can find the external jugular vein, as we mentioned it before, at the sternocleidomastoid region. So this external jugular vein, it's coming from the sternocleidomastoid region downward, and it goes to the lateral cervical region, respectively, in the medial portion of the omoclavicular or the major supraclavicular or greater supraclavicular fossa, and is perforating. As you see, it's perforating the investing layer or the superficial lamina of the cervical fascia, and it goes deep, and it's reaching to the and it's draining usually to the subclavian vein. This, of course, this external jugular vein in this area of the lateral cervical region is receiving a vein, variable superficial vein from the transverse colli or suprascapular vein and anterior jugular vein as well, which is all of them, they are draining to the external jugular vein. At the here you can see the course of this triangle. So we said the supraclavicular. So then we have the in this lower portion of the lateral cervical region, we have the sensitive nerves that they are arising from the punctum nervosum or the nerve point or Erb's point, that it's going downward, and they are subdivided to the lateral, intermediate, and medial, and they are the group of the nerve which is called supraclavicular nerves, which is responsible for the innervation of the region above and below the clavicle, and also the upper thoracic region in anterior side till to the deltoid region. So they are sensitive innervation, responsible for the sensitive innervation of this area, and some fiber also they are innervating the superior part of the mammalian region or the breast. So as you see, these nerves, they are divided as a lateral. Here you can see the lateral supraclavicular. Then you can see the intermediate, or sometimes you can see as a middle supraclavicular, and finally the medial supraclavicular nerve, that they are all these nerves, they are coming from the punctum nervosum or nerve's point, and also they are passing deep to the superficial layer or investing layer downward, and then when it reaches near to the clavicle, they are again piercing and perforating this investing layer, and then it's going more cutaneous and superficial, and it's innervating the anterior wall of the thorax and till the deltoid region. So then if we remove this investing layer of the cervical fascia, then you will reach and you will see in the lateral cervical region this important muscle, which is the inferior belly of the omohyoid muscle. This inferior belly of omohyoid muscle, as we mentioned it, the posterior cervical triangle, this triangle, it's dividing this triangle to the two main parts. One is upward, this is the inferior belly, One is the upward triangle or upper triangle, which is bigger, of course, and it's called the omotrapezium triangle. This is omohyoid inferior belly, and this is the trapezius muscle, or in English terminology, occipital triangle. And also the lower to the inferior belly of the omohyoid in the lateral cervical region, you have another triangle which is called omoclavicular triangle, which is in deeper portion. It's called the greater supraclavicular fossa. Then, of course, the deep part of this this area, it's covered by the or is formed by the scalenic muscles. So we know that the scalenic muscles, they are divided to the anterior, middle, and posterior. So you can see here the anterior scalenic muscle, which is more located medially. Then here you can see the middle scalenic muscle, that it's going a little bit laterally and behind. And then it's the posterior scalenic muscle that you can see here, that it goes the most posteriorly. After the posterior scalenic muscle, we have the levator scapula muscle, which is here. And finally, the most posterior one is the musculi spleni, that it's the most posterior. All these muscles, that they are the deep muscles of this area of the lateral cervical region, they are covered by the prevertebral lamina of the deep cervical fascia that is enclosed or covered by this, covering these muscles. As I mentioned, that the upper triangle, it's the occipital triangle or omotrapezius triangle, which is bordered by the sternocleidomastoid anteriorly, the trapezius posteriorly, and inferiorly by the inferior belly of the omohyoid muscle. The content of this triangle, it's very important nerve, which is accessory nerve. Accessory nerve, it's coming from upward and from the superior region in the inner surface of the sternocleidomastoid, and it going obliquely and downward and laterally and posteriorly, and it's innervating the not only sternocleidomastoid but also the trapezius, and the fiber is arising from the spinal root of the accessory nerve, cranial nerve number 11. Parallel with this accessory nerve, also you can find a group of the lymph node in the deep region, which are the deep lateral cervical lymph node, also is clinically important. Then another structure that in this occipital triangle you can find, it's the some branches of the thyrocervical trunk. So as you know, the thyrocervical trunk is a branch of the subclavian artery, which is arising from the intrascalenic part of the subclavian artery, and it's giving 4 branches. The inferior thyroid, which is, we discussed it already. It has a close relation with the recurrent laryngeal nerve, with its branch, which is the inferior laryngeal artery. But in this occipital triangle, you can see this artery, which is called ascending cervical artery. You can also see it in this area, this ascending cervical artery, which is usually in front of the anterior scalenus muscle. It's located together with the phrenic nerve. And next artery in the occipital triangle or omotrapezius triangle is the transversus colli, or arteria transversa colli, or transverse cervical artery, which is variable. Either it can be arising from the thyrocervical trunk usually, or it can come from the extrascalenic part of the subclavian artery. So there is a variation in this area. This is the structure that you can find in the occipital triangle, also in front of the scalenic anterior scalenus muscle. Also, you can find this phrenic nerve that is ascending usually together with the ascending cervical artery. So those are the superficial relation structure of the superficial relation with the scalenic anterior scalenic muscle. So those structure. Then, of course, dorsally behind the anterior scalenic and in front of the middle scalenic muscle, you can find the brachial plexus that it's passing above the subclavian artery that we mentioned it inside the scalenic fissure. So this is the scalenic fissure, which is here you can see in the lower portion of the occipital triangle, you can see the passage of the brachial plexus, the part of the brachial plexus that is coming out of the scalenic fissure. So this is the structure that you could see, and in this case, then the inferior belly of the omohyoid, further it's dividing the lower portion of the lateral cervical region to the omoclavicular triangle, which is bordered by the superiorly by the inferior belly of the omohyoid muscle. The anteriorly is by the posterior margin of the lower portion of the sternocleidomastoid, and the inferiorly is bordered by the clavicle, the middle third of the clavicle usually. So this is the border for the omoclavicular triangle, and the content of this the omoclavicular triangle from anterior or superficial to the deep region. The first one, it's the subclavian artery. We already we are going to mention it in the scaleno-vertebral triangle, that it's coming again and again. Be careful, the subclavian vein, it's coming from the axillary vein. It continue from the axillary vein, it continue as a subclavian vein, and it goes superficial to the anterior scalenic muscle, which is here. But the subclavian artery, it's going to the scalenic fissure. It means that behind or deep to the anterior scalenic muscle. So the subclavian vein that you can see, it's going from the omoclavicular triangle. It's going farther to the scaleno-vertebral triangle as a most anterior or superficial structure, and during to its pathway is receiving the external jugular vein, and the variable dorsal scapular vein also is draining to this subclavian vein. Then, of course, the scalenic anterior or anterior scalenus muscle, which is here, it's the next structure that it's deep to the subclavian vein, as I mentioned it, and deep to the anterior scalenus muscle. Then, as we mentioned, it is subclavian artery. Again, you can see that it passing through the scalenic fissure, and according to that, the course is divided as an intrascalenic part, which is giving the, for example, here you can see the thyrocervical trunk, which is here, and it's internal thoracic artery downward, it giving, and vertebral artery it gives also, and then it goes to the scalenic fissure between the anterior and the middle scalenic, and inside this fissure it gives the costocervical trunk, which is further, it's giving the deep cervical artery and the highest intercostal or intercostal suprema artery from the costocervical trunk. This is the relation of this structure according to the passage of the anterior scalenic muscle. Also, you can find very nice preparation. Here is the suprascapularis artery or suprascapular artery, which is also it's seen here. And this is the also it can be branch of the thyrocervical trunk or as a separate branch, also as a variation. It's arising from the subclavian, but mostly it's the branch of the thyrocervical trunk that is going directly toward the scapula, and it passing above the superior transverse ligament of the scapula, going above that ligament, and below this ligament, as we said, is supraclavicular nerve that it's going under this bridge like ligament to the posterior aspect of the scapula, and is discussed in the brachial plexus, the supraclavicular part. Finally, you can see the posterior border of the scalenic fissure, which is the middle scalenic muscle or musculus scalenus medius, and of course through this scalenic fissure, subclavian artery, and above that the brachial plexus, they are passing. So in this case, the recapitulation, the most superficial is subclavian vein, then you will have the anterior scalenic muscle, then inside the fissure subclavian artery, and the brachial plexus, and then the medial scalenic fissure, which is enclosing the scalenic fissure. So here we have the lateral cervical region. Lateral cervical region, English, it's posterior cervical region. It's divided by the pathway of the omohyoid muscle. The omohyoid muscle here is carotid. It's divided to the omoclavicular and omotrapezius triangle. The omoclavicular triangle, which is between the inferior belly of the omohyoid muscle and the clavicle, which is both of them here, it's carotid. In this area, you can find the branch of the subclavian artery that it's passing through the scalenic fissure, as you can see, between the anterior scalenic muscle and middle scalenic muscle. There is a scalenic fissure which is passing the subclavian artery, and above that the roots of the brachial plexus. And according to this pathway, we divide the subclavian artery to the intra, inter, and extra scalenic part of the subclavian artery. Be careful that the subclavian vein it's passing superficial to the anterior scalenic muscle. Just remember for that. Regarding the intra scalenic part of the subclavian artery, it gives the important branch, which is here, is the vertebral artery. And the vertebral artery, as we said, it's going cranially. It goes to the it's also a component of the scaleno-vertebral triangle, and it goes to the transverse foramen of the cervical vertebra at the level of the C6 till C1, which is different with the pathway of the vertebral vein, which is at the level of C1 till C7. Then we have a nice preparation here, which is the thyrocervical trunk, and it's also a branch of the subclavian artery, the intrascalenic part, and it gives several branches that it sometimes in some branches is variable. Here you can see the inferior thyroid artery that it's going upward and then horizontally, and it's reaching to the inferior inferior part of the thyroid and the posterior part of the thyroid gland. And supply also, it has a close relation. You can see this is the artery, the inferior thyroid here it pass here, and it has a close relation with this nerve that we already mentioned. It's located at the fissure between the trachea and esophagus. Here is the recurrent laryngeal nerve in the right side, which is turning around the subclavian artery, and it going back to the neck. So during to the operation and the ligature of this artery, so you have to be careful of the passage of the recurrent laryngeal nerve. Then next branch of the thyrocervical trunk, that in the lateral cervical region you can find is the ascending cervical artery, which is going parallel and superficial to the anterior scalenic muscle. And as we mentioned, this artery is passed together with the phrenic nerve. So phrenic nerve and ascending cervical artery, they are at the anterior surface of the anterior scalenic muscle. And finally here you can find another branch of the thyrocervical trunk here. It's the superficial cervical artery, which is going transversally crossing the roots of the brachial plexus and crossing also the anterior scalenic muscle, and it goes superficially to the passing through the lateral cervical region. And another artery that also it can be here is cutted, it's the suprascapular artery, that it's going toward the scapular notch, and it passing above the superior transverse ligament of the scapula, which is in this suprascapular. Also it can be a variable artery or branch of the thyrocervical trunk, which is the transverse cervical or transverse chole artery. Also sometimes can be branch of the thyrocervical trunk, but usually is branch of the extrascalenic part of the subclavian artery. So in this preparation, I'm going to discuss about the cervical plexus. As we mentioned, the cervical plexus is formed by the joining of the ventral or anterior branches of the spinal nerve segment C1 till C4. The cervical plexus, it's located approximately in the region of the sternocleidomastoid muscle. Is the region that is separating the anterior cervical region from the lateral or posterior cervical region. This region is the region that the muscle sternocleidomastoid is originated from the sternum and the clavicle, the upper part of the manubrium of the sternum and the medial third of the clavicle, and it's inserted to the mastoid process and superior nuchal line. So that's why the cervical plexus is located below the sternocleidomastoid muscle, and as a matter of fact, is the continuation, is the superior or cranial continuation of the scalenic fissure. If you remember scalenic fissure, here it's the subclavian artery, and here they are the beginning of the brachial plexus. They call it roots of the brachial plexus. And they are between the anterior scalenic muscle and the medial scalenic muscle is this fissure, which is called the scalenic fissure, and it passed the subclavian artery, and above that the roots of the brachial plexus. So if we continue in this part, we are reaching to the place of the cervical plexus. The cervical plexus is giving the branch, sensitive branch and the motoric branch. Regarding the sensitive branch of the cervical plexus, they are arising from the point that is called punctum nervosum. English terminology is the nerve point or Erb's point. It's located approximately in the middle halfway of the length of the sternocleidomastoid, or the superior to this midway length of the sternocleidomastoid in this region, which is called nerve point, or the punctum nervosum, or Erb's point, that they are arising the sensitive branch of the cervical plexus. The first branch that I'm going to discuss is this branch, and it's arising from this punctum nervosum. It's the lesser occipital nerve. The lesser occipital nerve, it's coming from the posterior, as you see, the posterior margin of the sternocleidomastoid muscle, and then it's going superiorly, and it's supplying the sensitive innervation of the skin of the lateral part of the occipital region. So as we mentioned it, in the occipital region, we have innervation by the lesser occipital, which is arising from the cervical plexus, and also we have the greater occipital, which is arising from the dorsal branch of the segment C2, and finally in the mid part of the or midline of the posterior aspect of the occipital region, or mid part of the occipital region, is the third occipital nerve, which is a dorsal branch of the spinal nerve segment C3. So this is the lesser occipital. The next nerve that is here, and you can see very well here, it's the greater auricular nerve. The greater auricular nerve, or the nervus auricularis magnus. It's arising from the segment C2, C3, and it's coming superiorly on the surface of the anterior surface of the sternocleidomastoid, and it's directed toward the auricle. This is the auricle, and when it reaches to the auricle, then it's subdivided to the anterior branch and the posterior branch according to the position of the auricle. The anterior branch of the greater auricular nerve, it's innervating the skin of the anterior part of the auricle, and also it's supplying the very important region, which is the parotidomasseteric region. The upper part of the parotidomasseteric region also is innervated by the greater auricular nerve. And finally, the posterior branch of the greater auricular nerve, it's going behind the auricle, and in this case it's innervating the skin of, or sensitive innervation of the skin of the posterior part of the auricle and the mastoid region. Then the third branch is this branch. This is called transverse colli, or the transverse cervical nerve, or nervus transversus colli. This is arising usually from the segment C3, and it's coming from the punctum nervosum, or Erb's point. It's continue anteriorly, and it's going over the sternocleidomastoid. All this cervical plexus is covered by the deep cervical fascia. So then when it's coming forward and more superficially, they can piercing the investing fascia, and they go toward the skin. So this transverse cervical nerve, it's going under this muscle, which is called the platysma. This platysma, as you see, it's if you dissect it in the neck region or upper face region. So if you cut the skin, then you remove the subcutaneous connective tissue, and this then immediately you will reach to the platysma. The platysma, it's dividing the subcutaneous connective tissue to the superficial and deep layer, and this transverse cervical, it's going to the under the platysma, and also it's dividing to the two parts, the superior part and the inferior part, or the superior branch and the inferior branch. superior branch is innervating the suprahyoid region, and the inferior branch is supplying the infrahyoid region. So very important connection of the transverse colli or the transverse cervical nerve from the cervical plexus with this nerve, which is the ramus colli or the cervical branch of the intraparotid, arising from the intraparotid or parotid plexus of the fascial nerve, that it's coming downward and it's supplying the platysma. So this ramus colli or the cervical branch of the parotid plexus of the fascial nerve, which is composed of the motoric fiber and it innervating the platysma, it's connecting with the superior branch of the transverse cervical nerve that is arising from the punctum nervosum, and it's the sensitive nerve. They are anastomosing together, as you see here, and it's called the superficial ansa cervicalis. This is the ansa cervicalis superficialis, which is, as a matter of fact, is the mixed nerve that it's composed of the motoric fiber arising from the fascial nerve, the intraparotid plexus or parotid plexus, and the sensitive nerve arising from the cervical plexus from the punctum nervosum. So this is called superficial ansa cervicalis or ansa colli superficialis. And finally, the last pure sensitive branch of the cervical plexus. Those are those nerves that it's going or is directing caudally, and it's arising from the segment C3, C4, and it's going after the Erb's point or the punctum nervosum downward, and then they are directed according to their place to the medial, intermediate, and the lateral supraclavicular nerve, or they call it the supraclavicular nerves. Those nerves, they are arising from the segment C3, C4 that I said, the medial one, that it's going downward, and in the internal surface of the clavicle, in the internal surface of the sternocleidomastoid muscle, and then it reached to the jugular fossa, and it's innervating the skin around the jugular fossa and the manubrium of the sterni. So those are the three direction: the medial, intermediate, and the lateral one. This one is the medial one, that it's supplying the skin of the jugular fossa and manubrium of the sterni. The intermediate, it's passing caudally, and it's going to the lower part of the neck region and the clavicle. So and it's supplying the infraclavicular part, the skin of the infraclavicular part, the skin of the middle part of the clavicle, and the lower part of the lateral cervical region. And finally, the lateral one, it's the caudally and dorsally it goes, and it's supplying it's responsible for the sensitive innervation of the skin around the acromial region of the scapula. So these three nerves, the suprascapular nerve, they are passing from, or they are arising from the punctum nervosum, and they are passing over the clavicle, and they are, according to their pathway, as we said, they are dividing to the medial one and intermediate one and the lateral one. That the region, as I mentioned, it is innervated by these nerves, the sensitive innervation. Then the last thing, as I mentioned, the cervical plexus, it has also some motoric nerve, and this motoric nerve that is not seen here, they are responsible for innervation of the muscles of the anterior part of the neck region, or anterior group of the cervical region at the vertebra, in front of the vertebra, and some suboccipital region. So these are generally, they call the muscular branches, that they are coming from the C1 till C4, and they are for example, the musculus rectus capitis lateralis, or rectus capitis anterior, also the longus colli and the longus capitis. They are the muscles that they are innervated by this motoric, or the rami muscularis, or muscular branches of the cervical plexus. And very important nerve, it's arising from the cervical plexus, is phrenic nerve, that I'm going to discuss. Next region of the neck that I'm going to discuss is called the scaleno-vertebral triangle. Scaleno-vertebral triangle, it's the triangle which is extended above the superior thoracic aperture, and in this triangle, or in this region, it's also extended the parietal pleura, which is covering the apex, and is called cupula pleurae. This triangle clinically also is important, because cranially it's communicating with the carotid triangle, and caudally it's communicating with the mediastinum. So to understand the approximate site of the scaleno-vertebral triangle, if you find the inferior portion of the sternocleidomastoid muscle, if you remove the sternocleidomastoid muscle, then you reach this scaleno-vertebral triangle. So as a matter of fact, the anterior or ventral border of the scaleno-vertebral triangle is the inferior portion of the sternocleidomastoid muscle. So here you can see that there is a manubrium of the sternum. The sternocleidomastoid muscle is removed, and the clavicle also is removed. Here you can see the course of the first rib, which is attaching to the costal fossa or fovea of the or costal notch of the manubrium of the sternum, and then followed by the second rib, which is attaching to the sternal angle, which is determining the level of T4. So here, so we said that regarding the borders of the scaleno-vertebral triangle, the anterior border is the sternocleidomastoid muscle. So these red dots, they are determining the course of the sternocleidomastoid muscle, the inferior portion, which is originated from the sternal part and the medial part of the clavicle. So this is the origin of this muscle. So ventrally sternocleidomastoid muscle. Then the dorsal border is bordered by the musculus longus colli. The longus colli muscle, it's the posterior border of the scaleno-vertebral triangle. Then the medial border, there are the visceral organs, mainly the trachea and the esophagus, that behind the trachea is passed. So it's the organs that you can find it in the medial border of the scaleno-vertebral triangle. And finally, the lateral border is formed by the anterior margin of the anterior scalenic muscle, which is forming the lateral border of this triangle. The base of this triangle, or floor of the triangle, is formed by the copula, as we said, copula of the pleura, that it's making a arch to the height of the neck of the first rib, and it's going above approximately around 2 centimeter. Here is the course of clavicle, so approximately 2 centimeter above the medial end of the clavicle, and it's connected by the ligament connecting this pleura to the first rib, and this ligament is called costopleural ligament, which is connecting the pleura to the first rib, which is here. So, and finally, the apex of this triangle is at the level of the carotid tubercle of the 6 cervical vertebra, which is approximately here at the level of the transverse process of the C6 vertebra. You have very large anterior tubercle that because in the case of the emergency and in case of the bleeding, you can compress the common carotid artery against this tubercle of the transverse process of the C6, and you can decrease the amount of the bleeding till the patient it goes to the hospital. So that's why it's called carotid tubercle. So once more for the recapitulation, the lateral border is the anterior scalenus muscle. The medially, it's the cervical organ, like a trachea and esophagus behind that. Sometimes in some literature, you can see the thyroid gland also is included. Then the ventral portion was the sternocleidomastoid muscle, which is removed here dorsally by the longus colli muscle. The apex was the carotid tubercle, and the floor by the cupula of the pleura. This triangle, it's very important because if we remove the sternocleidomastoid muscle, behind that, the first structure that is the most anterior structure, it's the subclavian vein. Subclavian vein, as you see the course, it's going in front of the or superficial to the scalenus anterior or anterior scalenus muscle. It's going above the first rib, and it continue, and it's joining with the internal jugular vein, and they form the angle which is called the venous angle. This venous angle is very important because on the right venous angle, it's open the right lymphatic duct, and in the left side, the same side of the junction of the subclavian and internal jugular vein, we have the left venous angle, which is in this part, it's open the thoracic duct. Usually this thoracic duct, the course of the thoracic duct from the superior mediastinum, it's going dorso-ventral direction over the, here is the right side, but over the left subclavian artery, and it's opening to the left venous angle. But in the right side, it's the place of the opening of the same course, the opening of the right lymphatic duct. The right, the thoracic duct is receiving the lymph from the approximately 3/4 of the body, and the right lymphatic duct only 1/4, approximately the right side of the head and neck region, right side of the upper limb, and the upper portion of the thorax in the right side. So as you see, so here you have this structure that the thoracic duct on the left side, and the right lymphatic duct on the right side, it open to the venous angle. The subclavian vein also, as we mentioned it before, it's receiving the blood from the external jugular vein that it was on the surface, superficial surface of the sternocleidomastoid muscle. In this region, it's passing and it going to the medial portion of the greater or major supraclavicular fossa or the omonclavicular triangle, and it open usually to the subclavian vein. Of course, there are variation as well. So the behind the subclavian vein, of course, we have the subclavian artery. The subclavian artery, as we mentioned it in the arterial portion of the anatomy, so it's on the right side. The subclavian artery is arising from the brachiocephalic trunk, which is dividing to the common carotid artery and the subclavian artery. And this subclavian artery, it goes through the scalenic fissure, which is the fissure between the anterior scalenus muscle and middle scalenus muscle. And according to this course, the subclavian artery is divided to the intrascalenic part, interscalenic part, the portion that is inside the fissure, and then extrascalenic part according to the course of the subclavian artery inside the subclavian fissure. And of course, in this area, the intrascalenic part of the subclavian artery, it's giving the branches that we already mentioned it. So the vertebral artery, it's the major component of this triangle, the scaleno-vertebral triangle. That's why sometimes this triangle is called triangle of the vertebral artery, and it's crossing the ventrally the root of the lower root of the brachial plexus at the level of C8 and T1, and it's passing toward the transverse foramen of the cervical vertebra C6 till C1, but as we mentioned it, through the transverse foramen of the cervical vertebra C7 till C1, it passed the vertebral vein. So in this case, the component of the scaleno-vertebral triangle, in this case also we have the common carotid artery and the subclavian artery, which is in the right side arising from the brachiocephalic vein, and on the left side is directly coming from the arch of the aorta. Between the subclavian vein and subclavian artery, we have the vagus nerve. So if you want to find the vagus nerve in the scaleno-vertebral triangle, you have to search it between the subclavian vein, which is located more superficially, and subclavian artery, which is located deep, and it goes to the scalenic fissure. And this vagus nerve, then it enter to the superior mediastinum and continue parallel with the wall of the esophagus to the posterior mediastinum as the esophageal plexus, and anterior and posterior vagal trunk that they are continuing to the abdominal cavity through the esophageal hiatus. But on the right side, the vagus nerve in this area around the subclavian artery, it gives a branch which is turning around the subclavian artery, and is going back to the muscular triangle between the trachea and esophagus, and it's going in the lateral side or fissure between the trachea and esophagus, and it's called the recurrent laryngeal nerve, just the right vagus. So here in this area, it gives the recurrent laryngeal nerve which is going through this scaleno-vertebral triangle. Then it continue to the muscular triangle or omotracheal triangle. Then the next component of the scaleno-vertebral triangle is phrenic nerve. Phrenic nerve, it runs lateral to the vagus nerve. So vagus is more medially, and phrenic nerve, it runs lateral on the surface of the anterior scalenus muscle. Usually is accompanied with the ascending cervical artery. And again, the same, it continues to the thorax, to the superior mediastinum, again between the subclavian vein and subclavian artery, and then it's followed to the side of the pericardium together with the pericardial cophrenic vessels in the middle mediastinum. As we mentioned it, to the scalenic fissure, we have the roots of the brachial plexus, which are passing and above the subclavian artery in this area. The other component of the scaleno-vertebral triangle is the sympathetic trunk. Sympathetic trunk is the deepest and most medial structure which is located in the scaleno-vertebral triangle and is enclosed by the prevertebral lamina of the deep cervical fascia. And this sympathetic trunk, you can find it superficial to the roots of the brachial plexus. Then, of course, in this triangle, you can find the middle cervical sympathetic ganglion, which is usually at the level of the C6 is located. Then you can find the satellite ganglion, which is, as a matter of fact, is the fusing of the inferior cervical sympathetic ganglion with the first thoracic sympathetic ganglion, and they form the satellite ganglion, and the location is approximately above the head of the first rib and in front of the vertebral artery, just near to the copula of the pleura. This fusion of the lower or inferior cervical sympathetic ganglion with the first thoracic sympathetic ganglion is called satellite ganglion, or sometimes it's called cervicothoracic ganglion. The last thing regarding the scaleno-vertebral triangle, it's ansa subclavia or subclavian loop. Ansa subclavia or subclavian root is a nerve cord that is connecting the middle cervical sympathetic ganglion to the inferior cervical sympathetic ganglion, and that's why, because it's making a loop around the subclavian artery, so that's why they call it ansa subclavia, or the English terminology is subclavian loop.